Committee on Education and Labor will come to order, and I want to welcome everyone to the hearing. I know that a quorum is present. The committee is meeting today to hear testimony on examining threats to workers with pre-existing conditions. Pursuant to Committee Rule 7C, opening statements are limited to the chair and the ranking member. This allows us to hear from our witnesses a lot sooner and provides all members with adequate time to ask questions. I recognize myself now for the purpose of making an opening statement. Today we're here to examine the threats to affordable health care for workers with pre-existing conditions. I want to welcome our distinguished witnesses for agreeing to be here today and to testify on an issue that affects roughly 133 million Americans across the country. On March 23, 2010, President Barack Obama signed the Patient Protection and Affordable Care Act into law. Over the last 9 years, this historic legislation has improved the lives of countless Americans by making insurance more affordable and more accessible while strengthening the quality of health coverage and enacting life-saving consumer protections. The Affordable Care Act's success is even more remarkable in the context of the persistent attempts to repeal and sabotage the law. Since it was passed, the House Republicans called more than 70 votes to repeal all or parts of the ACA. Those efforts were punctuated by the American Health Care Act, a bill passed by Republicans in 2017, which gutted protections for patients with pre-existing conditions. According to the CBO, the repeal bill will have resulted in 23 million fewer Americans with health coverage, would have raised premiums by 20% the first year, while providing less comprehensive benefits, and would have jeopardized many of the consumer protections found in the ACA. The Trump administration has taken an equally aggressive approach to undermining the law. For example, the administration has expanded the use of junk plans that roll back consumer protections, raise the cost for most consumers, and have a troubling record of fraud and abuse. On June 19, 2018, the Department of Labor finalized a rule to expand association health plans. Under the rule, associations can sell coverage to small businesses and self-employed individuals without meeting certain ACA standards that would otherwise apply, such as the requirement to cover essential benefits, the prohibition against charging higher premiums based on factors such as gender or occupation, and the age rating limit, which prevents insurers from charging unaffordable premiums to older people. Extensive research has shown that association health plans create a few winners and a lot of losers. The report published by the Government Accountability Office in 2000 found that they are likely to increase costs for most workers who are not in association plans and make it harder for older, sicker workers to get affordable care. The prevalence of fraud in these plans is equally concerning. A 2004 Congressional Budget Office report identified 144 unauthorized or bogus plans from 2000 to 2002. Those plans covered at least 15,000 employers, more than 200,000 policyholders, and left unpaid medical bills over $250 million. On August 3, 2018, the Departments of Health and Human Services, Labor, and Treasury jointly moved to expand the use of short-term health plans. The departments issued a final rule to extend the allowable duration of short-term plans from 3 months to up to 12 months, with renewability up to 36 months. Under the rule, the short-term plans do not have to include federal consumer protections, including protections for patients with pre-existing conditions. Because of the risk of confusion and overall lack of consumer safeguards, not one single group representing patients, physicians, nurses, or hospitals voiced support for the rule expanding the use of short-term plans. The administration's final and most dangerous attack on the ACA is the unusual decision to side with a group of Republican attorneys general in a lawsuit against the federal government seeking to strike the ACA in court. So the Trump administration is effectively arguing the ACA's consumer protection should be invalidated along with the rest of the law. If this ultimately prevails, as it did in the district court in Texas, the result would be catastrophic. All Americans, whether insured through the ACA marketplace or through their employers, would lose consumer protections we all take for granted, including the elimination of lifetime and annual caps, the prohibition on lifetime and annual coverage limits, which protects workers from incurring unreasonable out-of-pocket expenses, Before the ACA, more than 90% of non-group plans had annual or lifetime caps on coverage, and a majority of the employer-provided plans imposed lifetime limits. Cost-sharing protections. The requirement that plans offer out-of-pocket costs to limit out-of-pocket costs to an affordable percentage of a worker's income. The elimination of pre-existing health condition exclusions. The requirement that all health care plans cover patients with pre-existing conditions at the standard rate. Last night, I was pleased to hear the President's comment that he wants to protect patients with pre-existing conditions and end the spread of AIDS. But as I said, the actions of this administration have jeopardized those protections, and people with HIV or AIDS could be excluded from coverage based on pre-existing conditions if those initiatives succeed. Preventive services without cost sharing. The protection that allows workers and families access to vital preventive care without paying out-of-pocket expenses, that protection would be eliminated. And while I appreciate that my Republican colleagues are now voicing support of many of these protections, their words have not translated into actions. On January 9th, Democrats voted on a resolution to empower the House Counsel to intervene in the Texas case to defend the ACA and protect people with pre-existing conditions. Only 3 House Republicans voted to support that resolution. There may be different views within the Democratic Party and across the political spectrum regarding the best path forward to further expand affordable health care. But we all must commit, both in our words and deeds, to maintaining the life-saving consumer protections enacted in the ACA, and we must refuse to go backwards. Until efforts to repeal and sabotage this historic legislation cease, workers with pre-existing conditions will be at risk of losing access to the care they need to live healthy and fulfilling lives. I now recognize the distinguished ranking member for the purpose of an opening statement.
Thank you, Mr. Chairman. Americans with pre-existing conditions need health insurance. This is a fact and a value that Congress and the President have affirmed countless times. It's also the law. Insurance companies are prohibited from denying or not renewing health coverage due to a pre-existing condition. Insurance companies are banned from rescinding coverage based on a pre-existing condition. Insurance companies are banned from excluding benefits based on a pre-existing condition. Insurance companies are prevented from raising premiums on individuals with pre-existing conditions who maintain continuous coverage. So it's perplexing why committee Democrats are even holding this hearing, and by doing so, they are making it about threats. Instead, this hearing should focus on how the strong economy, with its extraordinary job growth, is increasing the number of workers with employer-sponsored health coverage. This committee's work on employer-based health care options dates back to when the cost of health care began to rise several decades ago. The status quo was not sustainable. Then, and in 2010, the tide took a radical turn for the worse with the Affordable Care Act, which decimated options for employers earnestly seeking to provide competitive benefits packages to recruit and retain workers, and sent individual premium costs on an even faster upward trajectory. Workers paid the price. Employers paid the price. But after 8 years of Republican leadership in the House of Representatives and the election of President Trump, the U.S. economy and job markets are thriving, with consistent wage growth and greater availability of highly competitive jobs. Smart employers are continuing to ensure that they offer competitive benefits packages, including sponsored health care plans, to recruit and retain workers. And their efforts are working. According to the Kaiser Family Foundation, 152 million Americans, including many who have pre-existing conditions, are insured through plans offered by their employer. That's the majority of the American workforce and more than the individual market, Medicare, or Medicaid. Since 2013, 7 million more Americans have gained employer-sponsored health care coverage, with 2.6 million gaining coverage since President Trump took office. The plans employers offer are, on average, higher quality and provide better value than what can be found on the individual market. In 2017, the average premium for individual and family employer-sponsored coverage increased by a modest 3% and 5% respectively. In contrast, the average exchange premium, Obamacare, went up by roughly 30%. So if we're going to have this hearing at all, we welcome it as an opportunity to talk once more about the importance of making sure American workers have more options, more flexibility, and more freedom. Last Congress, the Republican-led House of Representatives passed the American Health Care Act. The legislation would restore stability to the health care marketplace and deliver lower costs to consumers. Ensuring protections for individuals with pre-existing conditions was a central piece of the bill, with Section 137 of the legislation stating, "Nothing in this act shall be construed as permitting health insurance insurers to limit access to health coverage for individuals with pre-existing conditions." So people may have an opinion, but they cannot argue with the facts. The facts are written in this legislation, Section 137. Republicans on this committee also led the passage of the Small Business Health Fairness Act. That legislation would empower small businesses to band together through association health plans, AHPs, to negotiate for lower health insurance costs on behalf of their employees. And last summer, the Department of Labor finalized a rule expanding access to AHPs. During the 115th Congress, House Republicans also passed the Competitive Health Insurance Reform Act and the committee-led Self-Insurance Protection Act. What all of these bills have in common is their goal to expand coverage, lower health care costs for all Americans, and again, give freedom to Americans. Committee Republicans welcome this opportunity once again to assure Americans with pre-existing conditions that their coverage is protected. House Republicans will continue to champion legislative solutions to combat some of the most pressing problems facing our healthcare system, including skyrocketing costs, the high prices of certain drugs, the industry's lack of cost transparency, and the looming threat of a single-payer system. These are the factors that pose the real threat to Americans having options to work for them. I yield back, Mr. Chairman.
Thank you. Without objection, all other members who wish to insert written statements to the record should do so by submitting them to the committee clerk electronically in Microsoft Word format by 5 p.m. February 19th, 2019. I'll now introduce our witnesses. Our first witness will be Sabrina Corlette, a research professor at the Center on Health Insurance Reforms at Georgetown University's McCourt School of Public Policy, where she directs research on private health insurance and market research. Prior to joining Georgetown faculty, she was the director of health policy programs at the National Partnership for Women and Families, where she focused on insurance market reform, benefit design, and the quality and affordability of health care. She's a member of the Washington, D.C. Bar Association. Chad Reedy, 37 years old, has cystic fibrosis. He lives in Alexandria, Virginia, with his wife, Julie, and 2 sons. In addition to volunteering for the Cystic Fibrosis Foundation, he has spent the last 13 years working in the real estate industry. Grace Marie Turner is president of Galen Institute, a public policy research organization she founded in 1995 to promote free market ideas for health reform. She has served as a member of the Long-Term Care Commission, the Medicaid Commission, the National Advisory Board for the Agency for Healthcare Research and Quality. Prior to founding the Galen Institute, she served as Executive Director for the National Commission on Economic Growth and Tax Reform. Dr. Rahul Gupta is the Senior Vice President and Chief Medical and Health Officer for the March of Dimes. He is one of the world's leading health experts, and in his role, Dr. Gupta provides strategic oversight for the March of Dimes medical and public health efforts to improve health care for moms and babies. Prior to joining the March of Dimes, he served under 2 governors and West Virginia's health commissioner, and as the chief health officer, he led the state's opioid crisis response efforts and several public health initiatives. We appreciate all of the witnesses for being here today and look forward to your testimony. Let me remind the witnesses that we have read your written statements and they will appear in full in the hearing record. Pursuant to Committee Rule 7D, the committee and committee practice, each of you will be asked to limit your oral presentation to a 5-minute summary of your written statement. Let me remind the witnesses that pursuant to Title 18 of the U.S. Code, Section 1001, it's illegal to knowingly and willfully falsify a statement, representation, writing, document, or material fact presented to Congress or otherwise conceal or cover up a material fact. Before you begin your testimony, please remember that to press the button on your microphone in front of you so that it'll be turned on and the members can hear you. As you begin to speak, the light in front of you will turn green. After 4 minutes, the light will turn yellow, and to signal you have 1 minute remaining. When the light turns red, we ask you to summarize and end your testimony. We will then we'll then let the entire panel make their presentations before we move to member questions. When answering a question, please remember once again to turn your microphone on. I'll first recognize Ms. Corlette.
Thank you, Mr. Chairman. Ranking Member Fox, members of this committee, it's really an honor to be with you here today and to discuss the need for affordable, adequate insurance coverage, particularly for those with pre-existing conditions. In my testimony, I will focus on some of the challenges faced by people with pre-existing conditions before the ACA was enacted and how current threats to the ACA could have disproportionately harmful effects on these individuals and workers. Before the ACA was enacted, roughly 48 million people lacked health insurance, and an estimated 22,000 died prematurely each year due to being uninsured. 60% of the uninsured reported having problems with medical debt, and the high number of uninsured was costing providers an estimated $1,000 per person in uncompensated care costs. The lack of affordable, adequate coverage also led to a phenomenon called job lock, where workers are reluctant to leave the guarantee of subsidized employer-based coverage for the uncertainty of the individual market. And for many people with health issues, job-based coverage could also be spotty or include barriers to enrolling. Prior to the ACA, in most states, people seeking health insurance could be denied a policy or charged more because of their health status, age, or gender, or had the services needed to treat their condition excluded from their benefit package. Indeed, a 2011 GAO study found that insurance companies denied applicants a policy close to 20% of the time. Under the ACA, these practices are prohibited. Prior to the ACA, coverage also could come with significant gaps, such as for prescription drugs, mental health and substance use services, and maternity care. Under the ACA, insurers must cover a basic set of essential benefits. Extremely high deductibles and annual or lifetime limits on benefits were also common before the ACA. The law protects people from both by capping the annual amount paid out of pocket each year and prohibiting insurers from placing arbitrary caps on coverage. Members of this committee are aware that the ACA is now under threat of being overturned due to pending litigation in federal court. If the plaintiff's argument prevails, it would be tantamount to repealing the ACA without any public policy to replace it. And this is a scenario that Congress rejected in multiple votes in 2017. Congress rejected it because repealing the ACA without replacing it would result in 32 million Americans losing insurance, double premiums for people in the individual insurance market, leave an estimated 3/4 of the nation's population in areas without any insurer, cause significant financial harm for hospitals and other providers due to uncompensated care costs, cause the loss of an estimated 2.6 million jobs around the country, and importantly for this committee, result in harm to people with job-based coverage, including the loss of coverage for preventive services without cost sharing, such as vaccines, well visits, and contraception, the return to pre-existing condition exclusions, young adults no longer allowed to stay on their parents' health plans, and insecurity due to crippling out-of-pocket costs for people with high-cost conditions. This administration has also instituted regulatory changes that have resulted in higher premiums for people in the individual market. These include the decision to cut off a key ACA subsidy, the dramatic reduction in outreach and consumer enrollment assistance, and the introduction of junk insurance policies that are permitted to discriminate against people with pre-existing conditions. The zeroing out of the mandate penalty has also increased premiums. While the bulk of the negative effects of these policies are felt by people in the individual market, these negative effects spill over into the job-based market. The ACA is by no means perfect. Even its most ardent supporters argue that more could be done to expand Medicaid and improve affordability for middle-class families. There are a range of policy options that this committee and others can explore to strengthen the law's foundation, while also building on its remarkable achievements. Thank you for providing this forum, and I look forward to the discussion.
Thank you. Mr. Reedy.
Good morning. Thank you, Chairman Scott, Ranking Member Fox, and distinguished members of the committee for inviting me to testify today. I'd also like to thank my wife, Julie, and my parents for being here today and their support. My name is Chad Reedy, and I have cystic fibrosis. I'd like to share my story of what living with CF is like and what the protections and the ACA mean to me and millions of other Americans living with chronic health conditions. CF is a rare genetic disease that affects about 30,000 people in the US and causes a thick, sticky mucus to build up in the airways, causing infections. There is no cure for CF. When I was diagnosed in 1984 at 3 years old, my parents were told that they should not expect me to live to age 12. Today I sit here at 37. I've been married for 12 years, and the father of our 2 boys, Liam, who is 8, and Tate, who just turned 7. Let me tell you what it's like to live with CF. Every day, I take 30 pills to help me breathe, digest food, and reduce inflammation in my lungs. I also take inhaled medicines and use a vest that shakes loose mucus in my lungs. 4 times a year, I go through a lengthy evaluation process with a team of doctors at Johns Hopkins. I do this to keep my lungs well enough to keep me alive. But I will never have the lung capacity of any of you sitting here today. When I was 26, I got really sick for the first time. My wife and I had just returned from our honeymoon when I started to notice that I was having a hard time breathing, performing normal, routine activities, like walking upstairs or talking on the phone. After a visit to my care team, I was admitted immediately to the hospital, where I stayed for 7 days, receiving intravenous antibiotics, chest physical therapy, and other procedures to stabilize my health. While my health care was covered under my employer-based insurance plan, when I returned home, I received constant reminders about how close I was to hitting my lifetime and annual caps. Before the ACA banned these practices, I would stay awake wondering, would I exceed my limits or be denied coverage? Then what? How would I pay for these things? The next time, in 2014, when I got very sick again, over 8 months, my lung function, which had been stable for 7 years, declined dramatically. I was so sick that not only was I missing work, I could not walk 10 feet across our living room floor without having to stop and catch my breath. I struggled to carry my kids, who at the time were 4 and 1. Things progressed to the point where we started to have conversations about needing a lung transplant just to stay alive. Thankfully, because the ACA was in place, I could focus on making a strong recovery instead of the financial hardships from all these medical bills. In January of 2018, I started on a drug that has changed my life, called Symdeko. It treats the underlying cause of my CF, not just the symptoms. It has brought more stability to my lung function, but most importantly, it has allowed me to be a better husband, father, and friend. I no longer worry when carrying laundry up a couple flights of steps from the basement. And when my boys are tired and want a piggyback ride or need extra love, Daddy's there for them. My treatments and care help me breathe a little easier and stay healthy so that I can work to help provide for my family, but they are expensive. In 2018, the total cost of all of my medicines was about $450,000. This does not include my care team, visits to them, or other procedures. While we spend a lot out of pocket, I am thankful that our insurance covers most of these. This is my story, and there are so many more like it across the country. For people battling rare and chronic disease, the policies we are discussing today are a matter of life and death. If the judge's ruling against the ACA stands and insurance companies are allowed to implement annual and lifetime caps, I would reach them in a matter of years and be on the hook for unimaginable financial costs. In addition, the cap on out-of-pocket sharing is vital for someone like me. I'm grateful that I have coverage that allows me to access a great team of doctors and cutting-edge medicines that help me fight this disease. Because of this, I have hope for a future where I grow old with my wife, see my kids grow up, graduate college, get married, and start families of their own. I'm not asking for you to take care of me. I do that myself. I also understand that the ACA is not perfect, but the protections it contains are critical to me and millions of other Americans with pre-existing conditions. I thank the committee for giving me the opportunity to share my story, and I ask that you work to keep our hope alive as you consider legislation as Congress. Thank you.
Thank you, Mr. Reedy. Ms. Turner.
Thank you, Chairman Scott, Ranking Member Fox, and members of the committee for inviting me to testify today. At the Galen Institute, we focus on ways to ensure affordable health coverage to all Americans, and particularly protection for the most vulnerable. I'm really pleased to be on the panel with Mr. Reedy, and thank you for so bravely sharing your story. I'm thankful for the healthcare system that supports your care and for continued innovation so new treatments can be available. Today in my testimony, I'm going to discuss the central role that the employer health insurance market plays in our health sector, new opportunities to reduce cost and expand access to coverage, and bipartisan support for pre-existing condition protections and the need for further improvements. 9 out of 10 workers are employed in the U.S. by companies that offer health insurance. These benefits are tax-free, both to workers and companies, a generous benefit, but one that leverages nearly $3 in private employer spending for every $1 in federal tax revenue losses. Employers and employees want the best value for their health care dollars and often work very hard to balance cost and quality. Long before the ACA, employers offered preventive services because they know that addressing health issues before they become a crisis can lead to better outcomes and minimize costs. These employers also play a vital role in supporting our health sector. Physicians and hospitals are paid much less under Medicare and Medicaid than under employer plans, and because private insurance pays more, they provide the margins that allow many hospitals and providers to stay in business. Leading proposals to expand Medicare coverage to all Americans would extend these public reimbursement rates universally, diminishing quality and access to care. The Trump administration is offering several options through its regulatory authority to help individuals and employees with more affordable care coverage. Chairman mentioned one of them, including association health plans. They allow small firms to group together to get some of the same benefits that large employers have. A Washington Post story just reported on a new study showing that AHP benefits are comparable to most workplace plans, and plans are not discriminating on patients with pre-existing conditions. States also have new flexibility under Section 1332 of the ACA to lower costs through risk mitigation programs. They separately subsidize patients with the highest cost, lowering premiums for others and leading to increased enrollment. In Alaska, premiums for the lowest cost bronze plan fell by 39% in 2018, and Maryland is seeing an even larger drop this year. Putting the sickest people in the same pool with others means that their premiums are higher. Virginia Senator Bryce Reedy talked with one of his constituents recently who said he makes a good living, provides for his family, but he said his health insurance premiums are $4,000 a month. And he said that's more than my mortgage, and really pleading for help. Unfortunately, many healthy people are dropping out of the market because costs are so high. There is strong bipartisan support for pre-existing condition protections. The ACA assures people cannot be turned down or have their policies canceled because of health status, and these protections are still in place. Legislation passed by the House of Representatives maintained pre-existing condition protection, but they don't work for everyone. Janet, asked to not use her last name, reported that she was diagnosed in 1999 with hepatitis C. She lives in Colorado and applied for the coverage in the state's high-risk pool. Her premiums in 2010 were $275 a month. Then her liver failed. She needed a transplant. The $600,000 bill was covered 100% with only $2,500 out of pocket. Colorado's high-risk pool was closed when the ACA started in 2014. Her premiums rose to $450. By 2018, they were $1,100 a month, the deductible of $6,300. But her anti-rejection medications were not covered. She said, almost everything I needed was denied, which threw me into a world of having to appeal to get the care I needed. She said, those of us who are self-employed and are not eligible for tax credits wind up footing way too much with the bill. She said her costs are $19,000 a year now before insurance pays, and she has to pay extras for her medication. She keeps her insurance because of something else happened and her liver failed and she needed another transplant. She said it would bankrupt my family. I hope to work with you to achieve the goals of better access to more affordable coverage and better protection with those with pre-existing conditions. Thank you for the opportunity to testify today.
Thank you. Dr. Gupta, before you start, I think I need to give full disclosure. I've been an active member of the volunteer for the March of Dimes for several decades, so I appreciate your testimony.
Thank you for being an active member, Mr. Chairman, and thank you, along with Ranking Member Fox and members of the committee, for the opportunity to testify today. My name is Rahul Gupta. I'm the Senior Vice President and Chief Medical and Health Officer at the March of Dimes. In addition to my role representing the March of Dimes, I also bring perspective from my experience as a practicing physician and as a former state health commissioner and a local health officer. As a primary care physician, it was not uncommon for me to treat women who were struggling with high costs of employer-based health insurance or priced out of coverage altogether due to their pre-existing conditions. These women were in the impossible condition of having to make choices between getting the care that needed, affording their families basic necessities such as food and prescription medications. Pre-existing conditions are common among Americans. 6 in every 10 American adult in the U.S. has a chronic disease, and 4 in 10 have 2 or more. Chronic conditions such as high blood pressure, diabetes, heart disease, and obesity can have tragic consequences for women during pregnancy. Each day in the United States, more than 2 women die of pregnancy-related causes, and more than 50,000 have severe pregnancy complications. More American women are dying of pregnancy-related complications than any other developed country in the world, and it's not getting any better. As pregnancy or childbirth are also widely considered pre-existing conditions, the prevalence of at least one pre-existing condition in this population is almost universal. If conditions like preterm birth, birth defects, or neonatal abstinence syndrome are considered, tens of millions of children could be subject to insurance discrimination throughout their lives. The Affordable Care Act contains a range of provisions to help ensure comprehensive, meaningful, and affordable coverage for women, children, and their families. Amongst its most important and popular provision is the requirement that health plans cover all individuals regardless of pre-existing conditions. The law ensures that all Americans can obtain coverage without worrying that they will be subject to discrimination, whether outright denial of coverage or carve-outs of the benefits they need the most. It's difficult for me to overstate the importance of ACA's requirements that all plans cover the 10 essential health benefits, including maternity care. The ACA has also addressed a range of issues related to affordability of coverage. Cost has historically been and remains one of the greatest barriers to care. If people are unable to afford coverage, healthcare becomes all but inaccessible. Under the ACA, policies sold on the individual and small group markets are prohibited from charging women higher premiums. Health plans can no longer impose annual or lifetime caps. In the case of maternal and childbirth and child health, these caps could be financially devastating. A woman, for example, with a high-risk pregnancy and delivery could easily exceed an annual cap, leaving her unable to obtain needed care for the rest of the year. Worse, a baby born extremely preterm who needs months of care in the neonatal ICU could exhaust a lifetime cap before even coming home. This triad of pre-existing conditions, protections, essential health benefits, and affordability provisions represent a three-legged stool that supports access to comprehensive, quality, and affordable coverage for all Americans. All three of these legs must be maintained to protect and promote our nation's health, and especially the health of women, children, and families. Marcia Dimes is deeply troubled by Texas v. U.S. This lawsuit appears to have been undertaken as a legal exercise, divorced from any real appreciation of its ramification for millions of Americans and their health and well-being. With the recent decision of the federal court judge to declare ACA unconstitutional in its entirety, the plaintiffs appear to be in a classic situation of the dog that caught the car. They were caught off guard by their own victory and now are unsure how to explain that. They have argued for an action that will cost millions of Americans their health coverage and potentially even their lives. In addition, we're deeply concerned about efforts by the administration to promote access to short-term limited duration insurance plans. These plans are not required to cover essential health benefits, including maternity care, mental health, and substance use treatment, and could again exclude or charge patients more based on their pre-existing conditions. Whatever changes may be undertaken to our nation's health laws and systems, they must be made with the express goal of improving access to coverage and care that is accessible, comprehensive, and affordable. In essence, this concept is no different than when I'm seeing a patient in my office. I endeavor to provide her with the highest quality care in a compassionate manner, keeping in mind that she shouldn't have to sacrifice her next trip to the grocery store in exchange. I sincerely hope that we can provide the same guarantee to all Americans. Thank you for holding this meeting, and I look forward to your questions.
Thank you. Thank you. Now we'll ask, have our members ask questions. I remind, first, I'm going to defer on my side, and gentleman from Connecticut, Mr. Courtney.
Thank you, Mr. Chairman. And again, I want to applaud the fact that we're holding this hearing in this committee. Back in 2009 and 10, when the Affordable Care Act was crafted with 3 different committees, it was our committee which led the way in terms of pre-existing conditions and all the patient protections, because we have jurisdiction over ERISA. Again, we actually were the place where the law was written. That was, in my opinion, one of the great steps forward of our nation in terms of social and civil rights. Again, Ms. Corlette talked about what the landscape looked like back in 2009 and 10. I brought along a flyer that that was being sold to a lot of businesses, which again brings back the bad old days. Again, it's a health plan where it's touted as great news for people who buy their own health insurance, a flexible health plan, affordable. However, if you flip to the back, it had sort of in the smaller print the fact that they may not be able to cover people who've ever had treatment for the following: AIDS, alcohol or drug dependence, cancer, COPD, connective tissue disorder, Crohn's disease, diabetes, emphysema, heart attack or stroke, hepatitis, inpatient emotional or mental illness, organ or tissue transplant, or colitis. So if you're like an episode of Survivor and you're not in that category, however, you're still not out of the woods yet, because it also says that other individuals who are obese, underweight, or have undergone diagnostic tests for a whole variety of different illnesses, as well as expectant parents or children less than 2 months old, are also not going to be able to take advantage of that policy. And lastly, it says this list is not all inclusive. Other conditions may apply. So, I mean, that's what health insurance looked like until President Obama signed the Affordable Care Act in March of 2010, which once and for all abolished this whole type of medical underwriting practice. And again, it was also architecture that was built around it to make that meaningful, such as essential health benefits, the lifetime caps, which Mr. Reedy so powerfully testified to, adjusted community ratings so that older people can't be charged more than 3 times a younger individual. So again, regarding the Texas case, as Dr. Gupta said, I mean, there's absolutely no question that the Justice Department, which participated with the plaintiffs and did not defend the Department of Health and Human Services, if that ruling were to stand, again, that would just take a wrecking ball to the whole architecture, again, that was built. Is that correct, Ms. Corlette?
That's correct. For the plaintiff states, if their position prevails, the entire law would be invalidated.
And in terms of some of the other changes that they've made through the regulatory process, the association health plans, which again, on surface sounds great, that small businesses can team together in different sectors and go out and buy collectively. By the way, that was totally legal prior to the Trump administration's ruling, and there were about 600 association health plans across the country. What the ruling really did was it basically allowed those plans to avoid, again, a lot of these patient protections, such as essential health benefits, which were painstakingly designed with the Institute of Medicine in terms of what is health care and what should health insurance be, and lifetime caps, et cetera. So again, I just wonder if you could sort of focus on that point, that the administration, again, is in fact undermining pre-existing conditions and pre-existing condition protections with those types of regulatory actions.
That's absolutely correct. Groups of employers have always been able to join an association and offer benefits if they choose to do so. What the administration is encouraging is arrangements that essentially are allowed to cherry pick the healthiest and youngest employer groups out of the regulated market and thereby gain a pricing advantage.
And the short-term plans, Dr. Gupta, you mentioned, again, it's the same story, is that it's really a device to avoid, again, the protections that were built into the Affordable Care Act.
That's very true. And along with that, the other part of this is the medical loss ratio that was built into the ACA, and that is not subject to in the short-term plan. So they can have as much as 50% medical loss ratio and actually profit disproportionately.
And the short-term plans are really not that short. Again, when the prior administration allowed for a very short-term plan, these now almost are basically going to be sold for an entire year. Isn't that correct?
Correct. They could be sold for about 364 days and then renewable afterwards.
Yeah, so, I mean, it's basically a whole new product. And again, we would see the bad old days in terms of, this type of laundry lists of fine print where people are going to have a rude awakening when they thought they had insurance, and in fact, it was totally useless and meaningless. I yield back.
Dr. Fox.
Thank you, Mr. Chairman. Ms. Turner, people living with pre-existing conditions such as cancer, diabetes, or other illnesses face an incredibly difficult battle each and every day. And in particular, I commend Mr. Reedy for his strength and courage to share his story with us today. People should have to worry. People should not worry about having their coverage denied because of a medical condition when they should be focused on getting well and managing their quality of life. That's what congressional Republicans have voted time and time again to protect pre-existing condition protections. Ms. Turner, are these protections under current law sufficient to protect access to coverage for the most vulnerable healthcare consumers? And do you agree that these protections should be maintained?
The protections absolutely should be maintained, but I do believe that we do have to address the issue of cost, because many people who need coverage are not able to afford it and then are completely exposed. So I believe that absolutely the pre-existing conditions that are in law today and that the House of Representatives supported in the American Health Care Act were important, will continue to be important, and I see the strong support both in Congress and with the American people to maintain those protections.
Thank you, Ms. Turner. Because of policies enacted by the previous House Republican majority and regulatory actions taken by the Trump administration, our economy is thriving. As I mentioned, the economy added 304,000 jobs last month, almost double what economists were expecting. As a result, the number of individuals with employer-sponsored coverage has grown by nearly 7 million since 2013, with 2.6 million gaining coverage since President Trump took office. How does strong economic growth contribute to more workers gaining health insurance from their employers?
Virtually all employers want to offer health insurance to their employees, but many smaller businesses in particular just can't afford it, both because of the regulatory burdens as well as the cost. The Trump administration is giving them some new options, both with association health plans and with health reimbursement arrangements. For those that have employer coverage, it's such a valued benefit. And employers and employees work together to balance cost and quality and comprehensiveness of benefits. And as a result, employer-sponsored health insurance is certainly the most popular benefit offered by employers. And I'm pleased to see that that's not only continuing, but being enhanced by the strong economy.
Thank you. When I travel, Ms. Turner, when I travel around my district in North Carolina, I hear stories from so many people who struggle with the high and sometimes unpredictable costs that they face when taking care of themselves and their families. Out of control drug prices, surprise medical bills are two topics that President Trump has recently identified as places for reform and areas where I believe we can find bipartisan agreement. In addition to these issues, what other areas do you think that Republicans and Democrats can move forward and work on together to find a solution that benefits patients, workers, and families?
You know, I do work with a number of people in the policy community, and it's surprising to see how much agreement there is on really trying to help people. I think we need to strengthen the system for the most vulnerable. I was on a panel yesterday, on Monday, with Academy of Health with several people from center left, and we talked about the importance of thinking of the whole person, of comprehensiveness of care, of allowing people to not only have coverage for health care, but housing support and food support and transportation support. Thinking of the whole person, I think, is really crucial, and devolving more power and authority to the states and localities that have the understanding of their markets and resources, I think is really crucial. But I also think addressing the cost of health coverage is so important. Between 2017 and 2018, we lost 2 million people in the individual health insurance market. They dropped out because of costs. So we've got to address the costs for people who want health insurance, who currently are healthy, but know they need protection. And we need to make sure that we're strengthening the system for the most vulnerable.
Thank you, Ms. Turner. I yield back, Mr. Chairman.
Thank you. Gentlelady from Oregon, Ms. Bonamici.
Thank you, Mr. Chairman, and thank you to all of our witnesses. Last week, there was a hearing in the Ways and Means Committee here in the House about pre-existing conditions, and one of the witnesses was the insurance commissioner from my home state of Oregon, Andrew Stolfi. And he talked about how in Oregon, since the ACA, we now have more than 3.7 million Oregonians, which is about 94% of our population with health insurance coverage. And since the ACA, that's been a significant improvement, significantly reducing the number of people without insurance. And before the ACA, insurers had offered limited coverage or excluded so many people who applied. In fact, before the ACA, the denial rate was about 30%. 30% of people who applied were denied. And in Commissioner Stolfi's words, he said, the ACA has helped to change all of this. Pregnant mothers know they can get the care they need and their babies need. Children with developmental disabilities can get all of the essential physician-recommended physical, occupational, and behavioral therapy they need to grow to their fullest potential. So the ACA is now protecting millions of people in Oregon who have pre-existing medical conditions. Lisa from Beaverton is 26 years old. She received a diagnosis when she was 23, stage 4 lymphoma. I'm happy to report that her cancer is now in remission and she's pursuing a master's degree, but she's pretty worried, frankly, when she hears all the conversations about repealing the ACA, this Texas lawsuit. She said, I have hopefully a lot of life ahead of me, and it frustrates me that my history of cancer could limit my access to health care. Mr. Reedy, thank you so much for sharing your story. I have an advocate in the district I represent, Ella, a young woman with CF, and she comes to the Capitol when she can to advocate for more research and funding. And her family shares your concern about lifetime caps. How has the last couple of years, how have you personally felt when you hear all these conversations about repealing the Affordable Care Act and when you hear about this lawsuit that might repeal the act?
Thank you. It is scary to think, especially like I testified earlier, with the cost of my care currently, having caps or potentially being able to be denied coverage is a scary thought, knowing that there is access to drugs that are changing my life and that there's more medicine coming down the pike that will ultimately, I fully believe, one day cure cystic fibrosis, but that will come at a cost. And it is hard to think or sort of comprehend that those treatments may be there, and because of a lifetime cap or because of being denied access, that I won't be able to get those medicines, or your constituent's daughter wouldn't be able to get those medicines that could potentially save or prolong her life.
Thank you so much, and you made an excellent point that access doesn't mean affordability, and if there's not the prohibition against discrimination for people with pre-existing conditions, if the companies are saying, well, we offer insurance to people with pre-existing conditions, it just costs a fortune, it's not meaningful access. I have another question to Dr. Corlette. I have another constituent, Diane, who's a small business owner. And for a long time, she has a son with autism and a small business. For a long time, she could not afford insurance before the ACA. She almost lost her home and business during the financial collapse. She went several years without coverage, and she was uninsurable because she had pre-existing conditions. So she was not able to manage her arthritis, made it difficult for her to work. So under the ACA, she was able to get coverage, she could see a doctor, she eventually had hip replacement surgeries, she's now able to work, has rebuilt her business. So really positive story, largely because of that access to marketplace coverage. So if Professor Corlette, if the ACA protections we've discussed are undermined, what might that mean for Diane and other small business owners who do look to provide coverage for themselves, their families, and their employees?
Sure. So if the ACA is invalidated in the Texas court, it will wipe away some of the protections that your constituent has benefited from. So, for example, in the group market, if she's buying as a small business owner, she could, or her employees could face what are called pre-existing condition exclusions, where the insurance company excludes from your benefit package those services that would actually treat your condition for which you actually need services for up to a year. The insurance company would not be required to cover essential health benefits, which is a list of benefits that the Institute of Medicine and others have said should be in a basic benefit package. could impose lifetime annual limits. There may not be a cap on the annual amount that she or her employees would pay out of pocket. So there are a number of critical protections that people in job-based coverage would lose.
Well, thank you very much, and I see my time has expired. I yield back. Thank you, Mr. Chairman.
Thank you. Dr. Rowe.
Thank you, Mr. Chairman. And Mr. Reedy, I want to start with you. First of all, the easiest vote I've made here in the U.S. Congress was for the 21st Century Cures Act. And to Dr. Collins, Francis Collins, director of the NIH, it's very easy for me to vote to increase his budget to $39 billion. When I was a medical student, the first pediatric rotation I had in Memphis was St. Jude's Children's Hospital. 80% of those children died in 1969 when I rotated there. Today, 80% of them live. If you have a rare condition, it's 100% for you. So I think there's a cure out there in the way, and I think your future is very optimistic, and thank you for being here today. Look, we could all agree that we want to increase coverage and access and lower costs. That's exactly what we wanted to do with the ACA. Everyone can agree to that. And we agreed that we wanted to discuss pre-existing conditions. And I want to go over very quickly so everybody understands that if you have health-based insurance, which I provided in my office for my employees, you cannot discriminate based on a pre-existing condition. Number two, if you have Medicaid or Medicare, you cannot discriminate versus on a pre-existing condition. It's only in the small group and individual market where this occurred. And people feared if they lost their job and they ended up in the small group or individual market that they couldn't do that. I have a bill that I'm dropping today, a very simple bill, has one paragraph, it's 3 pages long, that essentially provides ERISA coverage to the small group and individual market. It treats them, me, as an individual, and I've been on the individual market, exactly like a large corporation. And that solves the problem. And everyone in here, no matter what the court does, if the court rules whatever they rule, if they rule and it takes apart this, we have covered everybody and treated each individual exactly the same as a big company. This should be simple to do. It's one paragraph. And let me also say, Dr. Gupta, to you, let me share some experiences in Tennessee. We were promised the costs were going to go down. Our costs went up 175%, and we lowered the number of plans out there that we could have. In my district where I live, 3/4 as many people pay the penalty as actually get a subsidy. And what's happening in the real world is, with these out-of-pockets and co-pays at the hospital where I practiced for 30 years, over 60% of the uncollectible debt now are people with insurance, not without insurance, but with insurance. And what happens is, a patient would come to my office, and if they had a condition, one of the 10 essential health benefits, they got their screening procedure done, that was fine, that was, quotes, free. If I found anything wrong with them, and I had to send them down to the hospital for a test, they then have to meet their out-of-pocket and copay, which can be $3, $4, $5, in my family's $10,000. And so what happens, the hospitals, the providers end up eating that. That's what is happening in the real world, or people don't get the second test that they need, and that's what we have to look at. I also want to say to you all that I have a pre-existing condition. I was treated 18 months ago for prostate cancer. So I'm in that pool of pre-existing condition, and I don't want to be excluded either, nor do I want my patients excluded. And that's why I think we should all support this bill right here. And Ms. Turner, if you would, I would like for you to comment a little bit about my suggestion on just applying these ERISA rules to me or to any individual out there.
As we said, employers so highly value their employer coverage, and one of the reasons is because someone is negotiating on their behalf for a quality health plan. And health plans in the workplace are basically community rated. You may have different plan options, but everybody is basically paying the same amount for premiums. And HIPAA, of course, protections say that if you have group coverage through an employer and you move from one employer to another, that next employer must cover you at the same rate, so you can't then be basically underwritten. So there are a lot of existing protections in law, and I am very intrigued with your very creative legislation to basically extend those protections. I think it's important to note that if the Supreme Court, and I don't know anyone who knows what the Supreme Court's going to do, were to strike down the law, Congress is absolutely determined to fix it and to maybe improve the ACA in the process.
I agree, and one of the things that I think that is out there in the group market and the self-insured market, and we did this when I was on the city commission in my hometown, is that you can have disease management. Dr. Gupta knows this very well. And I've seen those cases where I have a friend of mine who has a large company with 15,000 employees, had a 1% increase in their premium per year for the last 5 years. And we can do that in the small group and individual market if we work together. Mr. Chairman, thank you. I yield back.
Thank you. Gentleman from California, Mr. Takano.
Thank you. Thank you, Mr. Chairman. Let me begin by saying that my home district in Riverside, California, we cut the Affordable Care Act enabled us to cut our uninsured rate by more than half because of expanded Medicaid and because of Covered California, which is the name of our exchange. I have personally spoken to older people in my district who have not reached Medicare age, but at an age when, if there were no ACA, they would not get any cost-sharing subsidies, and they could not have afforded the insurance. And they were very grateful that they got the cost-sharing subsidies so that they could reduce their exposure to a major medical incident. So the majority offers these really false solutions of association plans and short-term plans. Dr. Corlette, Ms. Corlette, could you, I think these plans are really evasions around minimum benefits. Is that correct?
That's right. So short-term plans are exempt from all of the Affordable Care Act rules, so they don't have to enroll people who have health issues. They don't have to cover the essential health benefits. And quite commonly with these plans, if you do get diagnosed with something after you enroll, they will do what's called post-claims underwriting and drop you from the plan in order to avoid paying your medical bills. So if you do have an unexpected medical event or diagnosis, you might find yourself uncovered. The concern is that they will siphon away healthy people from the Affordable Care Act marketplaces and result in higher premiums for those who aren't perfectly healthy and have to buy one of these ACA plans.
So it's the same for association plans, which were available, but the way the administration has structured them, a similar sort of result.
Association health plans are similar but not exactly the same. They do have to comply with some of the ACA rules, but not all, and so they can use essentially the rating advantage they have because they can charge higher rates based on age and other factors to cherry pick healthier employer groups from the ACA market.
And there goes the, any affordability gained by the ACA. So these are really ways to undermine the ACA and to undermine, by extension, protections for people with pre-existing conditions. Is that right?
That's right. If you have a pre-existing condition or you simply want comprehensive coverage, like maternity care or other things that you feel are important, you would be buying in the ACA market. And if healthy people are siphoned away, the ACA market risk pool will be smaller and it will be sicker, and insurers will price higher as a result.
So I would say that attempts to undermine the pools, undermine enrollment periods. So if we look at slashing funding for outreach and enrollment activities, that means less people enroll and makes these insurance pools less viable. That's also hurting people with pre-existing conditions.
That's right. There's no question that research shows that advertising, marketing, outreach, education, consumer assistance, those all work to get healthy people into the pool.
And this administration has, really refused to spend the outreach to get people to sign up for insurance, which then creates the premium dollar pool to make insurance viable and actually keep the cost down.
That's right. This administration has slashed outreach and marketing by about 80%. So it's hard to bring healthy people in if they're not aware that the coverage opportunity exists.
It was hard for me to square this president wanting to protect people with pre-existing conditions, knowing that his administration intentionally did that. So shortening the enrollment period, making it giving people less time to enroll into these insurance plans, has the same result.
That's right, and a number of the state-based marketplaces that can choose their own open enrollment periods have extended them to give people more time to enroll, and that's been a successful strategy.
Well, and the administration is also engaged in undermining the stability of the markets through ending the cost-sharing reduction payments for lower-income consumers. Would prevent people from being able to buy insurance because they don't have these subsidies.
It's absolutely the case that the decision by this administration to cut the cost-sharing reduction subsidy led to an increase in premiums in the individual market significantly, I think 20%.
Well, this intentional undermining in at least the three ways that I've spoken about, I mean, certainly reduces the viability of these healthcare exchanges, and also really makes meaningless any statement that this president wants to protect people with pre-existing conditions and their ability to get insurance. I yield back, Mr. Chairman.
Thank you. Gentleman from Pennsylvania, Mr. Thompson.
Chairman, thank you for hosting this hearing. Incredibly important topic. As someone who practiced healthcare for 28 years as a therapist, rehabilitation services manager, licensed nursing home administrator, I mean, this is an important topic, and pre-existing conditions is a serious issue, an incredibly important issue. I have been disappointed over the past couple of years where with pre-existing conditions, individuals living with pre-existing conditions obviously need confidence in their lives that they're going to be able to purchase insurance that they need to cover that condition for treatment, rehabilitation, but quite frankly, what I've been disappointed in is how there are people with pre-existing conditions need that. Healthcare professionals who are compassionate, dedicated, they want to provide those services. They want those patients to be able to access those services. Well, we've got a lot of politicians who have been weaponizing pre-existing conditions for political purposes. And whenever we do that, my experience, I've only been here, this is my 11th year. I was here in 2009, 2010. That doesn't serve anyone well. My background, I used to get very frustrated advocating for my patients, whether it was in a nursing home, comprehensive inpatient rehab, acute care, going to battle with insurance companies. People with some of the more chronic conditions are the ones that are facing those lifetime benefits. So I certainly support those improvements. But that said, I really want to clarify here. Ms. Turner, protections for individuals with pre-existing conditions has been a consistent area of agreement for both Republicans and Democrats. You stated that protections for people with pre-existing conditions are currently the law of the land, and under the American Health Care Act passed by the House last Congress, would the current law protections, legal protections for individuals with pre-existing conditions be retained?
If the Supreme Court were to invalidate the ACA and find the individual mandate both unconstitutional and non-severable, which I think is unlikely, but if it would certainly give several years of transition time before it went into effect, to give Congress ample time to figure out how to back up these protections. And as you said, the Congress, whoever has been in control of the Congress, has been a strong supporter of protection for pre-existing conditions. Even if people don't have them now, they think they could get them in the future, and they know someone who has chronic conditions. So those protections need to be in place, but they need to be in place in a way that actually allows the market to continue to work and doesn't drive out the healthy people because the costs are so high.
I mean, there's a lot of things that impact, I think, people getting into the pool, so to speak. That was mentioned by my friend from California. But the folks that have gotten out of the pool, I think there's a significant number who have gotten out because of post-ACA, the cost, escalating cost. And people with pre-existing conditions that were pleased that they were able to get, they could get the insurance, but their costs have escalated. So we can't be complacent with the law as it is now, whether we have to take measures. One final question for you, Mr. Turner. We constantly hear about the challenges that small employers face when dealing with costs and compliance burdens of providing health insurance coverage to their employees. While some small businesses are able to offer health coverage, many simply can't afford to do so. And one option, among others, which was passed by this committee, is for the small employers to band together to provide economies of scale for purchasing health insurance through association health plans. What are other alternatives that encourage and enable employers, both small and large, to preserve and expand quality health coverage for their employees?
Well, I do think it's important to focus on association health plans because this recent study by a very well-respected analyst, Kev Coleman, said that he did not see that the plans, that these new association health plans were, which are offered in 13 states just in the 7 months since the rule was finalized, and offering more than 24 plans, that they really do provide an option for employers. I've been in seminars with HR directors of Fortune 50 companies and talked with innumerable small businesses. They want to negotiate benefits that their employees want, and they listen to their employees, and they are as comprehensive of benefits as they can afford and offer that coverage. So I think that it's important to give respect to the people purchasing these policies, that they will find a way to get to make sure people have coverage that is as good as they can afford rather than no coverage at all, which is where too many people are without these options.
Thank you, Mr. Turner. Thank you, Chairman.
Thank you. The gentlelady from Washington, Ms. Jayapal.
Thank you, Mr. Chairman. On October 31st of last year, conveniently just a few days before the midterm election, President Trump tweeted, and I quote, "Republicans will protect people with pre-existing conditions far better than Democrats," end quote. That was a pretty big flip-flop, given that the president and Republicans in Congress, including many on this very committee, spent most of last Congress voting to try to kill the Affordable Care Act and its protections for individuals with pre-existing conditions. In fact, I think I'm right about this. The only Republican members of this committee who didn't vote for the horrible Trump Care bill last Congress were the 8 new members who hadn't yet been elected. Now this administration is backing a lawsuit that could strip coverage for more than 133 million Americans with pre-existing conditions with absolutely no plan to replace that coverage. And if this ruling takes effect, more than 17 million people would lose coverage in the first year alone. So, to my Republican colleagues, which one is it? Do the American people deserve coverage for pre-existing conditions or don't they? Let me also point out that overturning pre-existing conditions protections would disproportionately harm racial and ethnic minorities. And Mr. Chairman, I seek unanimous consent to enter a written statement from the Asian and Pacific Islander American Health Forum into the record.
Without objection, and I want to remind our colleagues that pursuant to committee practice, materials must be submitted to the committee clerk within 14 days following the last day of the hearing, preferably under Microsoft Word format. The materials submitted must address the subject matter of the hearing, and only a member of the committee or an invited witness may submit the materials for inclusion in the record. Documents are limited to 50 pages. Documents longer than 50 pages will be incorporated in the record by way of a internet link, so that you must provide the committee clerk with that in the time frame, but recognize that years from now that link may no longer work. And I'll give you a couple of seconds at the end.
Thank you, Mr. Chairman, and noted for the future. So let me start with my first question for Ms. Corlette. Thank you for your testimony. In your professional opinion as a research professor at the Center on Health Insurance Reforms, let's go back a little bit. Why did it take an act of Congress to require insurance companies to insure people with pre-existing conditions?
Well, before the ACA, insurance companies, in order to make money, the business strategy was to enroll as many healthy people as you could, bring in their premiums, and pay out as little as possible in claims. So to do that, they engaged in what was called medical underwriting, which required people, when they applied for coverage, to submit health forms. They had lists of up to 400 different conditions that would cause you to be excluded from coverage. But essentially, that was the business strategy. What the ACA tried to do was change the business strategy away from risk avoidance to risk management.
Thank you. So just to be frank, insurance companies wouldn't cover people with pre-existing conditions because they're too expensive, correct?
Yes.
Okay. So Ms. Corlette, you also said in your testimony that the Affordable Care Act was enacted in part to correct serious deficiencies in health insurance markets that left millions uninsured and millions more with inadequate coverage. The reality is that the profit-seeking motives of insurance companies and big pharma are at odds with providing comprehensive care for everyone in this country. Do you believe that government should play a role in ensuring that corporate greed doesn't allow insurance companies to deny coverage to people with pre-existing conditions?
I think absolutely government needs to play a role, both in terms of financing, and I think it's important, this committee is as aware as anybody else that employer-sponsored coverage is the source of the biggest subsidy in the federal tax code. So critical role in terms of financing, but also to set the rules of the road. So to the extent that we have private market actors on the provider side or the payer side, that there are clear rules of the road to protect people who need help, which is individuals, consumers, small businesses.
So thank you. In 2017, this is again a question for you, Aetna's CEO was paid nearly $59 million. Cigna's CEO took home almost $44 million. United Healthcare's CEO, $27 million. So our healthcare system is underwritten by greed, and health insurance companies and big pharma are profiting off of sick Americans. Without the protections ensured by the ACA, do you believe that insurance companies would continue to guarantee coverage for people with pre-existing conditions?
No, I think they would go back to the business practices they were engaged in before the ACA was passed.
Thank you. The Urban Institute estimates that 17 million people will lose coverage in the first year alone if the Republicans' lawsuit stripping the ACA goes through. We have waited long enough for corporate executives to do the right thing, in my opinion. They simply aren't going to do so without government intervention, and that's why we passed the ACA, and Mr. Chairman, it's why we must go further. Ultimately, I believe we need to take the pure profit-seeking motives out of our healthcare system and ensure that the number one thing we do is protect every American's right to have healthcare. And so today we are united as Democrats in protecting the ACA, making it clear that we stand with millions of Americans who are at risk of losing coverage. But I am also determined to put forward a bold new vision for Medicare for all, something that the majority of all Americans support. As members of Congress, we're ready to listen to them and put people over profits. Thank you, Mr. Chairman. I yield back.
Thank you. Gentleman from Michigan, Mr. Wahlberg.
Thank you, Mr. Chairman. Protections for individuals with pre-existing conditions has been a consistent area of agreement for both Republicans and Democrats. We have to keep reiterating that. I strongly believe that these protections need to remain in place, and I voted and co-sponsored legislation to safeguard them and give peace of mind to patients, and that's a matter of record. I'm disheartened with my friends on the other side of the aisle's continued misinformation on our record on this issue. There was no Trump care. Nothing got to his desk. There was the Affordable Health Care Act that dealt with all of the issues of concern that the ACA brought up because it didn't work for many people who did have a health care plan that they paid for, but when they went to use it, so many of them didn't have health care. So I hope that changes at some point in time, the rhetoric that continues on. This committee has jurisdiction over employer-sponsored health insurance. I know there are some that believe we need to move beyond the employer-sponsored coverage. However, the employer-sponsored system currently provides health insurance for over 181 million Americans. So instead of forcing Americans off their plans that they like, or in the cases of union employees, forcing them to give up health plans that they worked hard for and made salary sacrifices to negotiate, we should explore ways to strengthen our employer-sponsored system, reduce costs, so more businesses can offer these good benefits to their employees. I constantly hear from small employers in Michigan who are dealing with the cost and compliance burdens of providing health insurance coverage to their employees. While some small businesses are able to offer health coverage, many simply cannot afford to do so. One option among others, which was passed by this committee, is for small employers to band together to provide economies of scale for purchasing health insurance through an association health plan. Ms. Turner, thank you for being here. As you know, in August, the Department of Labor issued a final rule to expand access to AHPs. In your opinion, when finalized, will DOL's rule help or hinder efforts to increase coverage for small employers and their employees?
It absolutely will provide them an important new option to negotiate benefits on behalf of their employees. Talking with another HR director who has a workforce of primarily medium and lower income workers, he said what happens is that as healthcare costs go up, it eats up their wage increases. So employees see their wages as flat, but part of their compensation, because too much of their compensation package is going to health benefits. Some employers are very creative, helping to provide coordinated care for people that they've identified that they have the greatest health care needs. So I think employers play an important role, and I think association health plans also play an important role, as well as the new health reimbursement arrangement rule, which would allow employers who can't afford and don't have the resources to actually provide coverage to give their employees a stipend to be able to purchase health insurance on their own. We've recommended they be able to combine salaries from two spouses, for example. One spouse may be offered health insurance at work, the other one can get a stipend to help make that a family plan rather than just an individual plan.
The beauty of more flexibility, creativity, and options that go on.
And also to recognize the competition out there.
Right.
Plans are competing, companies are competing, everybody's trying to do the best job to get the best value.
You mentioned in your testimony a study by Kev Coleman, a former analyst at the insurance information website, Health Pocket. In his study, what type of plans did Mr. Coleman find that AHPs were offering? And let me ask this as well, are essential benefits covered in the plans that he discussed?
His study by Kev Coleman showed that these AHP plans are offering benefits comparable to the largest employers that have negotiated these benefits for years, and that they are not discriminating against patients with pre-existing conditions. Many of these employers may have someone on their staff, maybe even a family member that has a pre-existing
Or themselves.
condition. Yes, and so they want those benefits, and they're really pressing the market to figure out how do you do that at a price that they can afford to purchase that coverage.
Thank you. I yield back.
Thank you. Mr. Morelli from New York.
Yes, thank you, Mr. Chairman, for holding this very important hearing, and thank you to the panelists for being here and for answering the questions, particularly Mr. Reedy. Thank you for your courage in being here and sharing your story with us. Back in 1993, I co-sponsored and helped pass a law in New York that provided community rating for all New Yorkers that were in small business in the individual marketplace, as well as ending the practice of, beginning the practice of having protections for pre-existing conditions, something I'm very proud of. So I took it as an article of faith that everywhere was like that. And then I became chair of the insurance committee about 15 years ago, and during the time of the implementation of the ACA, learned a great deal about what happens in the rest of the country. So this is very, very helpful in terms of understanding all this. First comment I would just make around coverage is we use the word coverage as though it means the same thing to everyone. The truth is, I remember as insurance chair when people would come to me and say I had out-of-network benefits, and it said out-of-network services were covered, yet it only covered 25% of my bill, and I have this huge balance that I have to pay. You learn quickly that coverage doesn't mean coverage, that it means different things to different people, and cost avoidance is a big part of trying to provide coverage. But I wanted to just talk a little bit about the definition, if I might. My daughter Lauren was diagnosed with triple-negative breast cancer just a few years ago, and she passed away about 17 months ago. I'd never heard of triple-negative breast cancer, but as part of the diagnosis, and when you begin to look at treatment, you look at genetic panels and what you can learn from the genome. And it turned out that in Lauren's case, while it wasn't passed on genetically, she did have a mutation in one of her genes. And so perhaps Ms. Corlette might be able to answer this. Is there a concern that genetic predispositions will be defined more broadly as pre-existing conditions in the way that some insurers view this or some people view it?
Well, there is a federal law that was enacted before the ACA. The acronym is GINA, Genetic Information Non-Discrimination Act, that does prohibit insurance companies from discriminating against people based purely on genetic information.
And does that include then predispositions based on other things that would affect chronic conditions?
With respect to the pre-existing conditions that we're talking about today, most insurance companies require you actually be diagnosed with a specific condition before it would be underwritten. Although I will say for short-term plans, they will look at your medical history, and even if you were not given a formal diagnosis, they might say that you had the condition, the cancer cell was in your body before you enrolled and might disenroll you because of that.
Yeah, because it's certainly hard to tell when it manifests itself and when it actually becomes a disease state. Also, to my colleague, Mr. Courtney mentioned, as he showed the panel, or the pamphlet, mentioned, or in the description had obesity, which that would be a pre-existing condition, presumably?
Yes.
And that would be the case even if you hadn't exhibited or manifested any disease because of that condition. Is that correct?
Correct.
And obviously that's not genetic in nature, but that is effectively underwriting, which could lead ultimately to pre-existing conditions.
Right.
And I did want to just mention coverage too, because when you have community rating, and we don't even do an adjustment in New York for community rating, it's all the same, and so that you have, as you get older, as I'm finding, you have more medical conditions as you get older. Young, healthy people, obviously we want in the pools, and adverse selection often leads people to avoid coverage until they have a reason for it. But the larger the pool, and the more that you essentially flatten the experience of the larger pool, is really what insurance is all about. The avoidance of that with some of the plans that have either high deductibles or that, in a sense, sequester the better risks is actually what causes the case of either uninsured or high premiums. Is that not right?
That's exactly right. You said it better than I ever could.
Yeah, and that's my real concern here, Mr. Chairman, members, is that as we talk about coverage, as I said, it's not all the same, and you could be left with significant balance billing for procedures where you thought you had coverage, and this notion of sort of shifting risk to other groups of less well people is essentially what I understand the administration's policy to be. Would you care to comment on that?
Yeah, I mean, with respect to association health plans, short-term plans, it's really about shifting the risk from young, healthy people to older and sicker people. So it's sort of rearranging the deck chairs without addressing some of the underlying issues about costs, which is, they're real. We have a cost problem in this country, but just creating new winners and losers is I don't believe, the answer.
Very good, thank you. I yield back my time.
Thank you. The gentleman from Alabama, Mr. Byrne.
Thank you, Mr. Chairman. I appreciate your holding this hearing. Ms. Turner, I'm sort of just a facts type person, and I didn't get here until I was elected in 2013, so I'm having to go back and sort of make sure I understand how we got where we are. When Congress passed Medicaid and Medicare, embedded in those programs was protection for people with pre-existing conditions. I think that's correct. And when they created some other public programs like TRICARE, they did the same thing. And then I think I was told that when HIPAA was passed in 1996, bipartisan bill, that we provided similar protection to people that are in group plans, employer-provided plans. Have I gotten that right?
Absolutely.
So I asked my staff to go back and look at the most recent numbers that we could get, which was 2017. 49% of the people in America are under an employer-provided plan. When you add up all the people in the public plans like Medicare and Medicaid, it's another 36%. So if I'm doing my math right, since at least 1996, 85% of the people in America have had protections on pre-existing conditions as a result of bipartisan acts of the United States Congress. Have I got that right?
Yes.
Okay. So there's another 15%, and every one of those people in the 15% is important. I don't think any of us can gainsay that, but sometimes we start talking about this, we forget that 85% of the people in America have got the protections that they need. So when we look at what happened in the Affordable Care Act, and I was not here when it was passed, so I was not a part of that debate, I've actually talked to people in my district who were in that 15%. In fact, the very moment I was running for Congress is when those notices went out to people who were told by the President of the United States that if they liked their health care plan, they could keep it. They actually came up to me at a high school football game where I'm passing out pamphlets and showed me the notice they got from their insurance company that said, we're canceling your health care plan. But here's our new one for you. And the cost was a multiple of what they were used to paying. And these people, while they were working people, they couldn't afford it. And ACA didn't provide those type people with the sort of help they needed financially to do it. So I've met those people across my district who now are uninsured because they can't pay their premiums. So let me just ask you, are there individuals, including individuals with pre-existing conditions, that the ACA might have actually materially hurt?
There are people who say that the coverage that they had before, even in the individual market, was better than the coverage they have now because it's more affordable. Some of them are facing deductibles of $10,000, and they say that I might as well not be insured because I can't meet that deductible. Another friend who had a liver transplant needs significant anti-rejection medications. And he says that a health savings account actually is beneficial to him because he knows what his out-of-pocket costs are going to be. He can pay that on a tax-free basis, and his catastrophic coverage actually was much better because it allowed him to see any doctor without so many restrictions. So yes, there are people who preferred the coverage they had before, but I absolutely agree with you that preserving the pre-existing condition protections is vital, and also not frightening people to think that they might lose it. I had a friend write to me saying that she was worried if the court case were to be successful that she'd lose her pre-existing condition protection in Medicare. And there's no reason for her to be so frightened.
No, there have been scare tactics out there like that. It's unfortunate because, particularly on Medicare, you've got older people, and they've got lots of other things that they're thinking about, and we don't need to be scaring them. We need to be helping them. I've talked to many members of Congress since I've been here. I haven't met a single person in either party that doesn't want to protect people that have pre-existing conditions. The question is, how do you do it? What's the smartest way to do it? What's the most cost-effective way to do it? But when you get up and tell the people of the United States, if you like your health care plan, you can keep it, and then they get a notice that says, no, I can't keep it, and the substitute is something I can't afford, you have materially hurt people in the United States. And everybody in this Congress, Democrat or Republican, we should all want to work together to make sure we help those people, because those are the good, hardworking people in America who depend on us to look after them. I appreciate your testimony, and I yield back the balance of my time.
Thank you. The gentleman from California, Mr. Harder.
Thank you, Mr. Chairman, and thank you to all of our witnesses for being here on such an important issue. Protecting folks with pre-existing conditions is the entire reason I ran for this office. On my district in the California Central Valley, this is my highest priority. Over 100,000 people in our district have health insurance only thanks to the Affordable Care Act. And those 100,000 folks were at risk of losing their coverage if the Affordable Care Act was repealed. And it was only after that vote a year and a half ago, almost 2 years ago now, that I decided to get on in and see what I could do to fix that. And I think the reality is in a district like ours, where nearly 50% of our individuals have a condition that qualifies as a pre-existing condition, this affects every single human being. Every person in my community has a loved one who would be affected if the Affordable Care Act was threatened. Every single person, including me. In my case, it's my little brother David. He was born 10 weeks premature, less than 2 pounds when he was first born, spent the first 2 years of his life in and out of a hospital, came out with a health care bill 104 pages long, and because of that, he'd be without insurance until he's 65 and on Medicare if we did not have protections for folks with pre-existing conditions. And Mr. Reedy, I'm really was so touched to hear your story. I think your voice gives power to millions of folks. I think we need to be humanizing these statistics. And so when folks think about what life is really like with a pre-existing condition, they're thinking about people like my little brother. They're thinking about people like you. And all of us, because the reality is each one of us has a loved one who would be affected by these changes. And in your testimony, you mentioned you had a cost of medical treatment $450,000 in 2018. Is that correct?
That's correct. That was just for the cost of medicines.
1 year, 1 year. And I think that in a district like ours, where we have a high rate of unemployment, we have a lot of folks that have real financial stress. There's not a lot of folks that could be impacted by that. I'm very interested, based on your own experiences, Mr. Reedy, how do annual lifetime caps affect patients with costly medical conditions?
So with the passing of the ACA and the ban on lifetime caps, and annual caps, it has allowed me personally and others with pre-existing conditions to have a better frame of mind to be able to focus on our health versus if I go and see this doctor or I get sick and I have to go into the hospital or have to have some costly procedure, what is that going to do? How close is that going to get me towards that cap? And then potentially if I get to that cap, what happens then? So not only are you dealing with having to fight to stay alive or have to focus on treatment regimens that can take 3 to 4 hours a day, in my case, you're also then focusing on the mental aspect of this also and trying to focus on, if I get to this point, am I gonna have to make decisions basically that affect my care and my family's well-being versus essentially dying or not being able to access that care, which then will shorten my life and others.
What do you believe would happen to people like yourself and the people you advocate for if the Affordable Care Act was undermined by the court in the Texas case?
I worry with if the court case is upheld, I worry that insurers will institute lifetime and annual caps again, that they will reinstitute the ability potentially for me to be denied coverage simply because I was born with a genetic disease and have a pre-existing condition, and that I will lose the comfort knowing that no matter where I work or what happens to me, that I can continue to be there for my family and focus on what needs to happen versus to take care of myself versus what the cost of that medicine is that my doctor prescribed, or not even being able to go and see the highly specialized care that I need to take care of my lungs and my body.
Thank you for your powerful testimony and for putting a face on what this really looks like. I think there are so many of us affected, nearly 50% of my district and of many others. And we talk about millions of Americans. We talk about the 100,000 people in our community that would be without insurance if the Affordable Care Act were repealed and if it were undermined by some of these efforts of litigation. But I think the most important thing that we need to be considering is really understanding the day-to-day lives of folks who are living through these challenges today and understanding how those lives would be so different if we had not passed the Affordable Care Act. Thank you so much for your powerful testimony today. Mr. Chairman, I yield back my time.
Thank you. Gentleman from Georgia, Mr. Allen.
Thank you, Mr. Chairman, and thank you for having this hearing today. It's very enlightening. Obviously, I have some pre-existing conditions. I have family members that have pre-existing conditions, so we're all very, very interested in how we go about making health care available to all Americans. The question and the big debate is, how do we pay for it? Obviously, we have the resources in this country to provide, and Mr. Reedy, thank you for your testimony, to provide excellent medical care and hopefully a cure. We're all praying for cures for Alzheimer's, for all types of issues that we're dealing with in this country. And we're spending a lot of money to try to find cures for those things. But in the meantime, what is the best way to provide health care? Now, the question is, does the government do it more efficiently than the private sector? And I think, Ms. Turner, is there any information, like for every dollar of taxes that we pay, how much of that dollar actually gets back to take care of a patient under the Affordable Care Act?
I haven't seen, well, there's a medical loss ratio, so
Yeah.
we know that based upon the company size, that either 20 or 15% of the money can only go to administration, the rest has to go to medical care.
Right.
But I do think that it's important to look at the approach that the American Health Care Act that the House passed in 2017 took. It actually dedicated specific resources to help people that have high health care costs, $123 billion, a similar amount in a Senate bill that didn't make it through, but that would have separately subsidized and provided extra money for the people that have chronic health care conditions. The ACA put them in the same market with everybody else, and that is raised prices to the point that you're driving the healthy people out. So there's a lot of evidence that if you separately subsidize those with the highest costs and the highest risks, you can lower premiums for others, get more people covered, and then focus on providing the coordinated care that people with multiple health conditions actually need.
Exactly, and right now, I think that Health and Human Services has a budget of about $1.2 trillion. It's the largest single piece of the federal budget. And, out of that $1.2 trillion, I'm interested, of course, my background is the business world, and I'm interested in exactly how much of that $1.2 trillion is taking care of Mr. Reedy. And I think we need to look at that, and then we need to look at what would it cost if we returned health care back to the health professionals. And we were able to, through programs, deal directly in our health providers, deal directly with our health providers, rather than go through HHS and these other agencies that have these huge budgets. And frankly, as I understand it, our health care in this country is much more expensive than compared to other industrialized countries in the world. Is that correct?
That's correct. Well, we're also the research center for the planet. The great majority of new prescription drugs, like the one that Mr. Reedy says is so valuable, are developed in the United States. We pay a disproportionate share both for the research and for the drugs, and also new medical technologies and other innovations.
Right. So we're subsidizing health care across the world? Would that be correct? How can we afford it? We're $21 trillion in debt. And of course, I don't know who's going to be paying my health care bills, but it's probably going to be one of my grandchildren or great-grandchildren. But we got to solve this problem. We have the ability to take care. I think, I tell folks back home, we got plenty of money to take care of folks, particularly those with pre-existing conditions. I just think it's all in Washington. And we need to get it out in our states and communities and make health care affordable. And with that, I yield back.
Thank you. Dr. Schreier.
Thank you, Mr. Chairman, and thank you to our witnesses today. I just want to say that I can't think of a more important topic to bring up today as our first hearing, because one thing that I have heard about from all of my constituents is health care, and that is their number one issue. And I sit here today not just as a member of Congress, but also as a pediatrician, a doctor who's taken care of patients for the last 2 decades, and as a person with type 1 diabetes. And so I really share a kinship with people in my district and in this country with pre-existing conditions. So I can report to you firsthand that my patients are worried. They are worried that either they or their loved ones will not be covered if they have a pre-existing condition, or that they will be priced out of the market, as we've been hearing a lot about. And they're worried even in these popular employer-based health plans that their prices are also going up and their deductibles are skyrocketing. And so, I came here to bring down costs and protect my patients and make sure that no family goes bankrupt because of medical expenses. And so I hear about these solutions like these short-term health plans. And you can imagine as a pediatrician that preventative care, essential health benefits, mental health care, well woman care, these are all critical, and that's why they are essential health benefits. And I just want to clarify, Dr. Gupta, you haven't had to communicate anything for a while, so I thought I'd give you a chance. Can you just be very clearly, are those services covered under these short-term health plans?
Thank you for that question. Certainly, they don't have to be covered. I mean, the idea of motherhood being a sort of pre-existing condition comes back after a decade again. The idea of well woman, well child preventive care, knowing that we're undergoing through an opioid epidemic today, that we're having a lot of adverse childhood experiences and a whole generation that is going to have to deal with as children and grow up, and that will be the future of this country. None of those things will be covered. Neither will be things like vaccinations. Those will not be covered. Mental health screenings, domestic violence screening will not be covered potentially. Of course, mammograms, pap smears, none of those things have to be covered.
Thank you. You are speaking my language. And then just also to clarify, do patients know that these are not covered when they buy these short-term, less expensive health plans that are proposed to be a solution to skyrocketing medical costs?
That will certainly be in fine print, as was mentioned today, and I'm sure that most of us are not going to realize until you get sick, and then that will be the time that most patients will realize that they were not covered for those services.
And to read that fine print, you'd need glasses like these. Okay, my next question is that I have seen in my own practice, the classic story was a girl with a terrible rash whose mom brought her in, and it had been weeks that they had been trying to deal with this at home with all the powders and creams and everything they possibly could. And when she finally came to me, it was a disaster. She did antibiotics and steroid creams. But she delayed care because of the cost of care. She knew that because of her deductible, it would cost her a lot to come in and that she may as well try everything in the kitchen cabinet at home. And so when I think about these short-term plans and that preventative care would not be covered, and I know how important those well child checks are, I just would like your opinion as to how many families will show up for that critically important primary care and preventive care if those are not free, provided for free.
We know from studies that compared to insured population, uninsured individuals tend to delay their care. That leads to lack of those preventive services, ultimately poor outcomes and more expensive outcomes, not just from health, but also from financial reasons. And what we saw after ACA was the amount of uninsured childbearing women went down from about 20% to 13%. So additional 5.5 million women got the care for things like maternity care. So those things are happening now that we will, again, walk back several steps, and we will end up the emergency rooms with uncompensated care as doctors' offices, while mostly in primary care, where we already have shortages of tremendous amounts across the field. And those offices will once again be seeing a lot of patients who do not have insurance. And like I often provide care for those without regards to the level of insurance they have.
Thank you, Dr. Gupta, and I yield back my time.
Thank you. Gentleman from Kentucky, Mr. Comer.
Thank you, Mr. Chairman. And I would like to talk about healthcare in Kentucky. Obamacare, or the Affordable Health Care Act, however you want to pronounce it, in Kentucky was a great deal for people who got free health care via Medicaid, but it was a terrible deal for working Kentuckians who actually have to pay for their health care premiums. In Kentucky, 30% of the state is on Medicaid. That's pretty much free health care. But the rest of Kentucky and the state who are working, struggling to pay health care premiums, they don't have a very favorable opinion of the Affordable Health Care Act. Ms. Turner, I'd like to ask you a question addressing the rising cost of health care, including premiums, deductibles, and out-of-pocket expenses. This is a huge concern for most Americans, and it should be a concern for the Democrats. What options do you think policymakers should consider when discussing how to lower the cost of health insurance and provide a variety of affordable options, especially for employers and workers?
I describe in my testimony a plan that I have helped to develop with a number of my policy colleagues called the Healthcare Choices Plan. And it basically recognizes the states have a lot more knowledge about their individual markets and the needs of their citizens. And it's very difficult for Washington to finely tune legislation enough to let them do what they need to do. So we've recommended formula grants to the states to let them figure out how do they make sure that existing populations are supported, but they have the flexibility to be able to get coverage not only for the continued coverage for them, but to make sure that new people can come into the market and afford coverage and quality coverage.
If there's one thing that I think all of us would agree on in both parties is that everyone should be protected with pre-existing conditions in healthcare. No one should be denied coverage based on their medical history. Given that, and given current law, Ms. Turner, are any reforms needed to ensure that individuals with pre-existing conditions have access to health coverage?
One of the things that several states have done is request waivers to use some of the ACA money to more heavily subsidize those with high risks to make sure they can have access to care and coverage. I talked about Janet in my testimony, who's now under ACA coverage in Colorado, but it's inferior coverage to the high-risk pool coverage she had before. States can fine-tune that, high-risk pools, invisible high-risk pools, reinsurance, to make sure those with the highest health care costs are covered. Devote money to them. You can not only lower premiums for others, but increase access for the healthy people we need to come into the market.
In Kentucky, prior to passage of the Affordable Health Care Act, we had a high-risk pool called Kentucky Access, and it was successful, but it was eliminated with the passage of the Affordable Health Care Act. Just to follow up on that question, would you say there are other factors that affect consumer access to health care?
Well, that's one of the reasons I believe these short-term limited duration plans are so important, because somebody may be in a bridge between, they've just graduated from college, they had coverage then, right. They don't have a job yet, they're older than 26. Somebody who's near Medicare eligibility needs bridge coverage. Somebody who's starting a new business needs to. There are people who need these temporary plans, right. And that's another option. Indiana had a great plan called the Healthy Indiana Plan, state-based plan, an account to make sure that people could get the preventive care they need, but they also had major medical coverage. There are a lot of other options, but I think that the state creativity, working with healthcare providers, is really valuable.
Thank you very much, Mr. Chairman. I yield back.
Thank you. Gentlelady from Illinois, Ms. Underwood.
So we've just heard from our colleagues, Ms. Fox and Mr. Comer, who mentioned how they support protections for individuals with pre-existing conditions. However, congressional Republicans and the Trump administration have had relentless attacks protections passed by the Affordable Care Act. And so many of my colleagues here voted more than 70 times to repeal parts of the ACA. Moreover, last August, the administration finalized a rule that expands short-term, limited duration insurance, commonly known as junk plans. Junk plans do not have to comply with key federal laws that protect patients, and they can pose a serious risk to patients with pre-existing conditions. Earlier today, along with Representative DeSaulnier, my Democratic colleagues and I introduced my first legislation in Congress to overturn the Trump administration's rule expanding junk plans. Insurers should never have the option to discriminate against patients with pre-existing conditions. So Dr. Gupta, can you tell us more about why they're called junk plans and what kinds of consumer protections can junk plans exclude?
Well, thank you. I think part of what's important is not just the pre-existing conditions protections, but also the affordability as well as the accessibility in terms of essential health benefits. So none of this is covered or required to be covered in the short-term plans or also as we term the junk plans. There are states that have taken a proactive lead like California, Oregon, New York, New Jersey, who's actually have worked to prohibit those plans in the way that they are today. And obviously, other states will have to do more, because what that does basically is sells people out there who may not be suspecting a bill of goods that they don't have no idea about. So unless they read the fine print, we're in so many ways stepping back to about a decade ago, and people, when they find that they need the help that they need, they're not going to be able to get it, because their preventive care, as well as a number of those essential health benefits, including maternity care, will not be covered. For example, prior to ACA, only 11 states required maternity care in individual plans. Only 13% of the insurers' individual plans covered maternity care.
That's why patients groups, including the March of Dimes, the American Cancer Society, the American Heart Association, are opposing the junk plan rule. Mr. Chairman, at this time, I'd like to ask unanimous consent to enter a letter from those patient groups opposing the rule into the record.
Objection.
Thank you. Dr. Gupta, what effects could junk plans have on patients' access to care, particularly patients with pre-existing conditions?
Ultimately, it'll cost their lives or their bank account or both. The challenge with that is when somebody needs the help, early help, to be able to detect cancer like breast cancer, colon cancer, or be immunized for important condition that could be communicable. We're seeing outbreaks of measles, for example. Those could get worse, and people will be diagnosed much later in their stage, and then they will not be able to be covered by those because of the pre-existing conditions clause missing, and therefore there will be, again, we'll lose life, and it'll cost us a lot more. It's just the least effective way of administering health care.
In fact, an analysis by the Los Angeles Times found that not a single group representing patients, physicians, nurses, or hospitals supports the junk plan rule. And 90% of the comments from the public on this rule were either critical or opposed the rule outright. So, Ms. Corlette, are you concerned that public opinion on junk plans was disregarded when the rule was written? What needs to be done to ensure the needs of patients with pre-existing conditions are truly represented in this debate?
Well, certainly with respect to the comments on the short-term plan rule, it would suggest that the administration's mind was made up about what they wanted to do before the rule was finalized, and the public comments did not make much of a difference there. I do think there is a real concern that a lot of people who are healthy before they sign up for these plans, have an unexpected medical event, and are left on the hook for thousands, tens of thousands of dollars in unpaid medical bills. Of course, for those who have pre-existing conditions, they couldn't buy these plans even if they wanted to. They would have to buy in the ACA market, but the ACA market will be more expensive. CBO has said it'll be about 3% of a surcharge on premiums as a result of these plans.
Thank you, Mr. Chairman, and thank you to all the witnesses for being here. I yield back.
Okay, thank you. Gentleman from Texas, Mr. Wright.
Thank you, Mr. Chairman. I want to thank all of y'all for being here today. Mr. Reedy, God bless you and your family. I think it speaks to your character and your determination that you're even here today participating, so thank you. Ms. Turner, I think you would agree that, you know, we should never have laws on the books that are unconstitutional, and when the Supreme Court made its decision on ACA, Chief Justice Roberts, of course, his opinion was that it was constitutional by virtue of being a tax. I thought that was a very slender thread, but that's the opinion. And if you take that thread away, then it follows that the law is unconstitutional. And as a Texas congressman, I'm terribly proud of my state attorney general for leading the effort in this lawsuit, because again, if the reason it was determined that it was unconstitutional was that it's tax, and you take that away, doesn't it follow that it's no longer constitutional? What is your opinion, Ms. Turner?
Well, this is going to go through the courts to determine whether or not the fact that the Congress did in fact zero out the tax penalty for individual insurance does invalidate the law. But I think the important thing is that we've seen since then, all of the efforts by you and others in Congress was to repeal and to replace the law. So I think we've seen that there are definitely places that improvement is needed, and to try to find a way to replace the coverage that people are relying on, but to allow markets to work better so that healthy people are not being driven out.
Yes, ma'am, and the key word there is replace. I think the assumption that if ACA had not passed, or if it had been ruled unconstitutional, that nothing would have happened, that there would have been no improvements in health care is a completely false narrative, just as if it were to go away tomorrow, we're not going to revert back to the status quo of 2009, because there was always, even in 2009, I don't know if you were part of crafting or helping either side on that. I was here then. I was the Chief of Staff for the ranking Republican on Energy and Commerce Committee. I sat in some of those meetings, saw the markup. There was always Republican alternatives that included coverage for pre-existing conditions, even going back to 2009. So this narrative that we keep hearing, that Republicans are somehow opposed to that or don't want it, is patently and demonstrably false. And it needs to stop because it's not true. My last question is this. It has to do with the idea that's being advanced by the other side. And we heard it earlier today about Medicare for all. Well, Medicare for all is Medicare for none. Would you agree with that? Can you speak to it?
It certainly would not be the Medicare that seniors know now.
If we do away, if we go to socialized medicine, where it's all run by the government, then doesn't Medicare cease to exist?
As I mentioned in my testimony, my colleague Doug Badger has done some research looking at these cross-subsidies from the employer-based system. With 170-some million people participating, they pay a higher rate to physicians and hospitals that allow Medicare and Medicaid to save taxpayer money and to pay a lower rate. But if those reimbursement rates went across the board, 40% of physicians and hospitals would find that they couldn't even keep their doors open. So we need the employer-based system. Absolutely. And the private sector, not only for its innovation, but for the money that it provides to support existing public programs.
Right. Thank you very much. Thank you, Mr. Chairman.
Thank you. The gentlelady from Georgia, Ms. Macbeth.
Thank you, Mr. Chairman. And I do want to thank you for holding this hearing today. And I'd like to thank the witnesses who are here to discuss the importance of protecting access to health care for all Americans. This is an issue that is deeply personal to me. I, myself, like millions of Americans, live with a pre-existing condition. As a two-time breast cancer survivor, I understand what it's like to have your life turned upside down by this very diagnosis. I was first diagnosed with stage 1 breast cancer in 2010, and after completing treatment, my cancer returned again in 2012. My cancer was detected because of a routine mammogram. I'll never forget the way that I felt when I first heard my doctor say the words stage 1 breast cancer. For each of the 2 cancer diagnoses that I received, I underwent surgery through a procedure called a lumpectomy to remove the remaining cancer, and I received radiation treatment and drugs thereafter. I did it all while raising my family and working full-time, and I can tell you I was terrified. Despite being lucky and having good health insurance through my job, I was still worried about my financial security. I was concerned about making it to radiation treatments, sometimes every single day for weeks, and then back to work, and then back home to raise my son, Jordan. It was exhausting both physically and emotionally, but I had to do it, just like millions of Americans out there who share a similar story to mine. I truly don't know what I would have done or what would have happened if I had lost that health insurance coverage. And I'm happy to say today that I am cancer-free, but Mr. Chairman, not everyone is as lucky as I am. And I'm worried for Americans and for those in my state of Georgia who might not detect their cancer or chronic health condition early on, when it is most easily treatable. The Centers for Disease Control and Prevention states that preventing diseases is critical to helping Americans live longer, healthier lives and keeping health care costs down. It is so important that Americans have access to the preventive services that are an integral part of the Affordable Care Act. These include screenings for certain cancers, screenings for type 2 diabetes, and other critical health services. And I am worried about their future and their financial security. We here in Congress, we have a responsibility to protect people. That's what we must do. Ms. Corlette, could you talk a little bit more about how the ACA protects patients and has created greater access to preventive services like breast cancer screenings or high blood pressure screenings, particularly how the ACA cost-sharing provisions impacts and also ensures Americans have access to these types of services?
Absolutely. Thank you for the question. So the Affordable Care Act requires insurers both in the individual market and in the employer market to cover a set of evidence-based preventive services without any cost sharing for the enrollee. And that includes many of the services that you mentioned in your statement, but also vaccines, contraception, tobacco cessation counseling, a range of services that not only prevent disease, but help keep people healthy over the long term. Those services can also help diagnose issues that people have and help get them early treatment in order to get a better outcome at the end of the day. So if the ACA were overturned or this decision in the district court in Texas is upheld, insurance companies would no longer have to provide that protection, and people would face cost sharing. And we know, and Dr. Gupta mentioned, that if people do face co-insurance or cost sharing for those services, they tend not to get them or they delay them.
Thank you. And my follow-up question is, how could the Texas litigation impact Americans' access and affordability of these life-saving services?
If the Texas decision is upheld, millions of people will lose their insurance, about 17 million in the first year and up to 32 million by 2026. It's well documented that people without insurance delay, forego care. Before the ACA, about 22,000 people died each year simply for not having insurance. For people with job-based coverage, they lose access to critical protections like the lifetime and annual limits that Mr. Reedy discussed, the protection against excessive out-of-pocket costs. ACA has a cap on that every year, as well as the preventive services and essential health benefits that you mentioned.
Thank you.
Thank you.
Gentleman from South Dakota, Mr. Johnson.
Thank you, Mr. Chairman. Mr. Reedy, you spoke so eloquently about your family. Are any members of your family with you here today?
Yes, my father and mother and my wife are sitting behind me.
I kind of suspected that was the case.
And of course, you were facing us during your testimony, and so I just want to take a minute to tell you, because you couldn't know, their faces were filled with an incredible pride during your testimony. And of course, you should feel good because you did a good job. You should also feel very good because they clearly are very proud of you.
Thank you.
I want to, almost every member of the committee that's spoken has done a nice job raising their voice in support of protections for people with pre-existing conditions. Of course, I want to raise my voice to echo theirs, critically important, and I'm glad we're having this conversation. I also like how the panelists, all in different ways, have called forth this important connection between employer-based health coverage and some of these pre-existing condition issues. I thought I was a little concerned, Ms. Turner, in your testimony. You talked about how 65% of employers offered health insurance in 2001. You mentioned that number had come down in recent years. I assume affordability is a key driver. Are there others that are maybe not as intuitive to me?
It's primarily affordability, and also because there are fewer carriers now offering coverage in the individual and small group markets. But one point that I think is so important about when employers do offer coverage, they have an incentive. They were offering coverage for preventive care before the ACA because they know it works. It's so much better to detect breast cancer at stage 1 than at stage 4. So helping their employees stay healthy, making sure that they have access to preventive care, and being able to access the diagnostics that they need early on for their coverage. So I think that employer coverage brings particular value to our health sector without the mandates. They know this is important because it works.
So I just want to make sure that I can square the math here. The number of employers who are offering this type of benefit has gone down. A number of people have talked about how the number of people receiving that type of benefit has gone up. Is that just macroeconomic trends, large employers getting larger and smaller businesses being the ones more likely to drop this type of benefit?
I could look further into the research, but based upon everything I've read since the ACA, the cost of compliance in providing health coverage to employees is significant. So it's not only the cost of the coverage, but also compliance. And if a company is hitting that near that 50 employee threshold where the employer mandate triggers, they will sometimes put workers on part-time. They will scale back their staffs to avoid having to trigger that employer mandate. So I think in some ways the employer mandate has actually worked against smaller employees offering coverage, and without it and with more flexibility, I think we'd see more participation.
This is an area of concern, and I suspect it's an area of concern for everybody on the committee, regardless of party or region. Because so many people, from Mr. Reedy to others, have talked about how, well, I had an employer-based coverage, or I had job-based coverage. It's clearly a really important leg of this stool about how we make sure Americans are covered, how they can get the health care service they need. Are there things that we can do to strengthen employer-based coverage? Because the trends you're talking about, we should not feel good about in this country right now.
What employers want most is flexibility to meet the needs of their employees without having to charge so much that health insurance eats up their employees' pay increases. So they're looking for affordability. They want more competitors. They want more options rather than having to meet such specific benefit requirements to really allow them to. There may be other benefits that their employees value more than the essential health benefits list. So giving them more flexibility to meet their employee needs and keep costs down would increase participation.
Thank you very much. Well, Mr. Chairman, I just think this is a critical area for further study by the committee, and of course I appreciate the time, and I yield back.
Thank you. Gentlelady from Connecticut, Ms. Hayes.
Thank you, Mr. Chairman, and thank you to all of the people who have come to share your testimony today. I really appreciate it on this very critical issue. Before I begin my questioning, I cannot underscore what my colleague, Ms. Underwood, said before she left, that while we hear everyone talk about protecting pre-existing conditions, our Republican colleagues voted more than 70 times to either roll back or repeal the Affordable Care Act, which really undergirds those protections. My questions this afternoon are for Dr. Gupta. In your testimony, you talked about how the Affordable Care Act has improved the lives of millions of Americans, particularly women and children, and this was strengthened by those 10 essential health benefits that we all know about. Of those benefits, we have mental health and substance abuse treatment. Do you think that those are important benefits to protect?
Thank you for the question. Absolutely. I think one of the things we have we are yet to appreciate is the increase in tens of millions of people across this country who are suffering now from substance use disorder that may not have been the case even a decade ago. And so a lot of when we look at the data, access issues, fear of being fired from their employer are some of the reasons that people do not seek care. So it's a big stigma issue as well. For women, things like breastfeeding supplies, very simple things like breast pump and not having to cost share on those things are another one of those things that we should be working to protect in addition to the maternity care benefits.
Thank you. Because I know we're talking a lot about pre-existing conditions, and our conversations are centered around genetic conditions or health-related diseases. So I'm happy to hear that you recognize that addiction is also something that causes that really further exasperates those conditions. It's undeniable that we are in a crisis with opioid addiction. In my own home state of Connecticut, we have had significant increases. Over the past 6 years, our numbers have tripled. In 2017, my state marked a grim milestone of over 1,000 opioid-related deaths. And in June of last year, we were on track to surpass that. In the district that I represent, 3 of the top 10 towns are the highest opioid deaths. This is no stranger to me. I grew up in a family that struggled with addiction. In my own hometown, 45 people died last year as a result of opioid-related deaths. Does the current opioid crisis make the need for mental health and substance abuse disorder coverage more important?
Absolutely, and again, when we talk about employer-based coverage, here's the real problem on the ground. When I'm seeing patients at a charity clinic who have substance use disorders, they're unable to have gainful employment because of their addiction issues, which need to be treated in the first place. And that allows them to actually gain and have meaningful employment to begin with. So I think it's very important for us to make sure that we have systems in place that allow the treatment and access to treatment for one of the biggest crises to face our generation today.
I appreciate you viewing this as a crisis and talking about treatment and coverage and health care as opposed to a criminal action, as we heard last week from our friends over at Purdue Pharma, who talked about people who were addicted to opioids as, I quote, reckless criminals. During your time at the Department of Health and Human Services in Virginia, you led several important initiatives to address the opioid crisis in your state. Could you tell us what impact the Affordable Care Act had on access to treatment for substance abuse disorder and families, not just the individual, but I am the daughter of an addict, so how families were impacted by the protections provided by the Affordable Care Act?
Absolutely. In a state like West Virginia, which is not any different from a number of states that are having to deal with this crisis firsthand on the ground, we found that having access to treatment, being able to expand those treatment and make that available, a part of which was Medicaid expansion. West Virginia was one of the first states that we worked very hard to ensure Medicaid expansion, allowed a number of people to enter the treatment spectrum, but we found that the access to mental health treatment, access to the medications, being able to transport it and being paid for being able to transport for treatment are some of those factors that help us remove the stigma of addiction and help us move forward in that. And it's very important that we reduce all the barriers to treatment when it comes to stigmatizing disease such as addiction.
Thank you for your time. Mr. Chair, I yield back.
Thank you. The gentleman from Pennsylvania, Mr. Muser.
Thank you, Mr. Chairman. Thank you, Dr. Fox. Thank you to all testifying today. Ms. Turner, I'm Dan Muser, Pennsylvania's 9th Congressional District, and I appreciate your taking the time here, and all of you. I believe every American should have access to high-quality, affordable health care, regardless of health status, including pre-existing conditions. Given current law, are there any reforms that you would feel, Ms. Turner, that are needed to ensure that individuals with pre-existing conditions do in fact continue to have access to health care coverage?
I don't think there's one particular answer, Congressman. I think they need a myriad of options. I think giving states the option to recreate their high-risk pools will be helpful to make sure people who have pre-existing conditions have a place to go. If their health insurance becomes so expensive, as Senator Bryce Reed's constituent described, $4,000 a month premiums or deductibles that are $10,000, they need other options. And I think states also could do things like the Healthy Indiana program, an account-based plan that allows people resources to access primary care, but knowing that they have major medical coverage as well. But I think the crucial issue is addressing cost and giving people more options, more flexibility to giving companies the option to provide coverage that's more attractive, that healthy people want to get in the market, so they're not staying out of the market, putting more and more people who have high health costs in the market and driving up premiums for everyone.
Okay, that's encouraging to hear. And now that we've established that we are in agreement on pre-existing conditions, I'd like to ask you your thoughts on the Affordable Care Act's effect on association health plans. In Pennsylvania, for instance, the Pennsylvania Farm Bureau had 12,000 members in an association health plan, and it worked very well along with other organizations. The Trump administration has issued a final rule allowing for the use of AHPs. However, many governors, Democrat governors, so happens to be across the country, including in Pennsylvania, are blocking the formation of AHPs. Can you speak to the importance of the efforts to allow AHPs and maybe comment as to, technically, as to why these efforts would be blocked?
So far, association health plans are available in 13 states, about 24 plans in all. And some states are considering invalidating or blocking these plans, which they have full right to do, just as they are short-term limited duration plans. But what they're doing is foreclosing options for people who are otherwise likely to simply be uninsured. If they don't have an affordable option, their family can not only face bankruptcy, but not having access to that good, high-quality care that private insurance brings. So it's unfortunate if states take a view that because, I don't know, their Trump administration rules, that therefore they should be opposed because they're providing options for people who are desperate for coverage.
Yeah. Okay, that is unfortunate. Thank you. Medicare Advantage. I've had people coming into my office and throughout my district speaking about how terrific Medicare Advantage programs are, how relatively affordable they are versus other Medicare plans. And as a matter of fact, the Medicare Advantage plans have reduced in cost by 6% this past year, when other plans on average are going up 12%. So would you say that this is an successful example of private sector innovation? And could you offer any other insight on the effectiveness of Medicare Advantage?
They were created, as you know, in 2003 through the Medicare Modernization Act and went into effect in 2006. And there was no real significant promotion of Medicare Advantage plans. It was offered as an option for private coverage to seniors, so they didn't have to be in something of a Swiss cheese of a program with the fee-for-service Medicare. They've been hugely popular. I think almost half of seniors now have individually selected on their own without any mandates Medicare Advantage plans, and these plans compete fiercely for seniors. They have to cover a basic level of, not basic, but very generous level of benefits, and many of the plans offer much more comprehensive coverage than people can get in traditional Medicare, and many of them also incorporate prescription drug coverage. I think that seniors see it's crucially important because it also provides an environment for coordinated care. Rather than going from doctor to doctor in fee-for-service traditional Medicare, maybe getting the same prescription with different names for the same, from different physicians, and then winding up in the hospital with drug toxicity. They have somebody looking out for them and being able to really coordinate and help manage their care. Very, very beneficial, and of course, these are private plans within Medicare.
Okay, do I have any more time, Mr. Chairman?
Not really.
Okay. Well, I yield the remainder of my time. Thank you.
Thank you. I appreciate it. Gentlelady from Florida, Secretary Shalala.
Thank you very much, Mr. Chairman. I don't want to add, a lot of my colleagues have asked the same questions I would have asked. I do want to point out that Medicare Advantage gets a lot more money than traditional Medicare, and therefore it's expected to provide a lot more benefits. It also pays dramatically for the kind of marketing that the private plans want to do. So we're paying with taxpayer money for Medicare Advantage significantly, and most analysis has shown that we're overpaying for Medicare Advantage given the benefits that are provided. I do have a couple of questions, so I want to ask Ms. Corlette. We focused here on pre-existing conditions, but would coverage for pre-existing conditions actually work very well if we didn't have the other consumer protections? I mean, we could all agree on pre-existing conditions, but if you don't take the caps off, pre-existing conditions are limited, and Mr. Reedy would have a very difficult time with CF.
Yes, absolutely. And in fact, New York is a great example of a state that had a number of pre-existing condition protections before the ACA was passed, but they had a very expensive individual market because they didn't have the other provisions that the ACA included, such as the subsidies to support people up to 400% of the federal poverty level to buy insurance, as well as the individual mandate penalty. So it's important to note that the ACA included not just pre-existing condition protections, but a number of provisions that were more holistically designed to try to make coverage accessible and affordable for people. All of those are, of course, have been at least preliminarily ruled to be invalid by the Texas court.
Thank you very much. And Dr. Gupta, yesterday the president said that he was going to invest the money in HIV drugs. And I want to ask you about that because it's very important in my district. We have the highest incidence per capita, and therefore I'm very supportive of any investment in HIV. But those investments don't work without a comprehensive plan around them. And could you talk a little about that?
Absolutely. Thank you for that question. So as opposed to the 1980s, where we had a challenge of diagnosing HIV, figuring out how to treat it and make it a condition, people were dying on the streets because of that. Now we have the challenge of finding those individuals who may not know that they have HIV. So screening, that's why we have moved to what we call universal screening, and you really have to opt out, otherwise most of us can need to get screened. The idea behind that is most people that may have HIV do not know they have HIV, and if they can be caught early and put in treatment, it becomes a chronic condition you can live with. You don't have to die because of the complications. Now, when you start to remove the other legs of that stool in terms of essential health benefits, then obviously those people are going to not want to be screened for that HIV, the diagnosis will not occur, and then they will not be treated. As a result, they will continue to transmit the disease, and we will result in having more cases than fewer cases, and our conquest to eliminate HIV from the United States will not happen anytime soon.
Thank you very much. And Ms. Turner, if I could ask a quick question about the flexibility you're talking about. Would it be okay with you if a state was willing to develop a plan that didn't, that continued caps, had covered pre-existing conditions, but in continued caps? Because, you know, private insurance is a mixed bag in this country. I've got 500,000 people in my own district that are covered by private insurance, but some of it is underinsurance because it has high deductibles. And how much flexibility would you give the states so that we would really recognize it as insurance and comprehensive insurance? Would you continue some of these consumer protections that we're talking about?
I think that it's important to recognize that that state officials have to answer to the same constituents when they're making changes, health policy changes, that federal officials do. And so that needs to be a conversation with their voters, and to make sure that they are answering the constituents' needs for affordable, quality coverage, but doing so in a way that may give them more flexibility. Some states in Medicaid, as you know, and I'm sure under your secretaryship, some of the waivers were approved to give states like Oregon, for example, a lot of flexibility within its Medicaid program in what benefits were covered. So I think states can better fine-tune the mandates than a Washington mandate. The Affordable Care Act has been changed already, either by administrative order or by acts of Congress, 70 times. So I think needing to give the states the flexibility to answer the needs of their constituents and know that their constituents actually can be better heard at the state level, I think is important.
I should point out that Oregon simply took the same package. It actually didn't mix up the package of benefits very much. I'm asking you specifically about caps and about pre-existing conditions. Do you think that states ought to be able, and the other consumer protections, ought to be able to waive those consumer protections? And would it actually be comprehensive insurance at the end of the day if they had flexibility on those consumer protections, including pre-existing conditions?
We see with states that are saying they don't want short-term limited duration plans, California, offered in their states, Pennsylvania, restrictions on association health plans. If states feel that those consumer protections are important, I believe that they will keep them. And if they feel that there needs to be some flexibility along with consumer awareness and transparency, then I think states should have the option of figuring out what works best for their constituents.
So you wouldn't favor ERISA protections for and overrule states using ERISA protections?
I think that right now we basically have, under HIPAA, we have the protections that allow people to go from their employer plan to another employer plan and maintain that continuity of coverage and not be discriminated against. So those protections are already on the books. And because of the community rating within employer plans, people are protected to make sure that their health status does not affect their premium costs.
Thank you. Gentleman from Wisconsin, Mr. Grothman.
Okay, thank you. We'll lead up Ms. Turner, and one more time, I think you've answered this, but it seems to me the Republicans, the Democrats, are all in favor of protecting coverage for pre-existing conditions. Could you just one more time tell us, we've said it so many times, but not as many times as the ads we have saying otherwise run against us in an election. Under current law, are workers with pre-existing conditions allowed to be charged more denied coverage based on their condition?
I'm sorry, would you repeat?
Under current law, are people allowed to be charged more denied coverage based on their conditions?
No, Congressman.
Okay, so that's the current law right now. Good. Now, we'll give you some other general questions. I'm from Wisconsin. In 2018, last year, Scott Walker worked with the Trump administration and CMS to approve a 1332 state innovation waiver, which caused our premiums to drop. You familiar with that situation?
Yes, I am, sir.
Could you talk about what we did in Wisconsin?
I mentioned actually in my testimony some of the impact that these plans have had. Of course, I can't find this chart when I'm looking for it, but they have been able to basically repurpose existing ACA money to help increase access to coverage to improve access to coverage for people with chronic conditions, pre-existing conditions, and therefore lower premiums in their general market. So a number of states have, Wisconsin is often taking the lead in health policy innovations and waivers, and I think that this is an important one to move forward with.
And at least I'm told that premiums dropped a little over 4%. Is that your?
Premiums dropped and enrollment increased as a direct consequence.
Good. And in the past, but before this type of thing, we saw incredible increases in premiums and open enrollment falling. We saw that in Wisconsin. Is that true nationwide?
Because the premiums was so much higher.
Right. As the premiums go up, people just throw in the towel.
Can't afford it. And they also, we talk about high deductibles. The deductibles are so high in the ACA plans that if people are not eligible for cost-sharing reduction subsidies, they basically say they might as well not be insured because they can't afford to pay the first $10,000 every year out of pocket before coverage kicks in.
I'm glad you mentioned association plans. My experience with healthcare in general, when you take a group, not a statewide group because it's hard for the state to duplicate it, but when you take a business with 1,000 employees or something, a lot of those innovative businesses were doing a very good job. One of the things they did is employer-based clinics, which saved tremendous amount of money for a variety of reasons. Is there any way that you can see that sort of thing can be duplicated through something like Obamacare, or is this the type of innovation that is why we want the vast majority of Americans, hopefully, still insured through their employer?
Well, the Affordable Care Act did allow some innovation incentives for people to do, not association health plans, I'm blocking on the name of the creative coordinated care plans within Medicare. And because the rules that were written around the Affordable Care Act were so strict, even plans like the Mayo Clinic and Cleveland Clinic and others that had been, Geisinger, that had been very successful in managed coordinated care couldn't make it work. So I do think that flexibility is really important and trusting employers. Some employers have said, for example, that they feel it's worth flying their employee to another state and family members to get care at a center of excellence, of cardiac care, cancer care. So they really do try to innovate to get the best value and the best quality care.
That's another thing. I did mention employer-based clinics, but these centers of value, flying people to other states, because an employer has the ability to hire somebody and do a good job. Now, I know there are a lot of people who always feel that setting up another big federal bureaucracy is going to work after that seems to have failed like 120,000 times in a row. But what you're telling me is the way that the private insurance plans, even for individual companies, and hopefully to be duplicated by associated plans, they are able to find ways to reduce premiums and reduce costs that really, as a practical matter, are not being duplicated with a government bureaucracy.
That's correct.
Thank you.
Thank you. The gentleman from Michigan, Mr. Levin.
Thank you, Mr. Chairman. I'd like to dig in a little more deeply to the Texas versus United States case, and I have a question to start for Ms. Corlette. In a departure from long-standing precedent of defending federal law against constitutional challenges, the Trump administration's Department of Justice filed a brief last year requesting that the court strike down several provisions of the ACA in the Texas case. Among the provisions that the administration argues should be overturned include guaranteed issue, community rating, discrimination based on health status, and pre-existing conditions exclusions. Last week, President Trump told the New York Times that he is optimistic that the ongoing Texas lawsuit will terminate the Affordable Care Act. Would you say that the Justice Department's decision not to defend the ACA is consistent with Republican promises to protect patients with pre-existing conditions?
Well, I would say that the Justice Department's position, if it prevails, would strike down the protections that the ACA provides for people with pre-existing conditions. So no, it's not consistent.
And how does this, his statement reflect the administration's approach to this issue? We're here to talk about.
Yeah, I have a little trouble divining exactly what the administration's position is, given that there do seem to be differences between what President Trump has said and what the Justice Department position is, so I'm not sure I can comment.
On what they're actually doing. So you pointed out in your testimony that Republicans never have come up with a proposal to replace the ACA, yet they continue with their efforts to unravel it, the most recent example being the Texas lawsuit. During the last Congress, when we were debating the Republican bill to repeal the ACA, Republicans proposed segmenting the population and dumping sick patients into high-risk pools. The CBO had the following assessment of this proposal. Less healthy people would face extremely high premiums. Over time, it would become more difficult for less healthy people, including people with pre-existing medical conditions, in those states to purchase insurance because their premiums would continue to increase rapidly. One of our witnesses, Ms. Turner, has put forth a similar proposal this morning or early this afternoon. Ms. Corlette, how do high-risk pools stack up as an alternative to the coverage provided through the ACA?
Sure. Well, we have a history of high-risk pools. Before the ACA, there were about 35 states that had high-risk pools. And they varied, they were different, but I can tell you that for people who were in high-risk pools, the premiums could be as much as 2 times the standard rate. They often had pre-existing condition exclusions, so the condition that got you denied coverage in the individual market, you didn't get covered in the high-risk pool for up to a year. They had annual and lifetime limits quite often, high deductibles, and often many of these high-risk pools limited enrollment. Even still, they operated at a loss, so they needed to be subsidized by the government.
Okay, thank you. I have a question for Mr. Reedy. In your testimony, you described the enormous cost of your medical treatments, totaling nearly $450,000 last year. Prior to the ACA, plans in both the individual and employer market were permitted to impose annual and lifetime limits on care. And many of them did, including more than 90% of the plans in the individual market. You, better than most people, can speak to the real-world impact of these limits. Based on your personal experience, how do annual or lifetime limits on coverage impact patients with high-cost conditions?
Thank you for the question. Annual and lifetime caps, for me personally, if they were allowed to exist again, would cause a severe financial burden on my family. Not just from the cost of having to pay for the care that I receive, but also from the impact that if I do reach that cap, what happens next? Do I have to pay for them out of pocket? And if I do, then those costs can be unmanageable. As you mentioned, my care last year just for the medicines was $450,000. That is a lot of money to take. And so the impacts of those caps, having them now, provide a peace of mind. They also know that I can continue to receive the highly specialized care and that I have access to that coverage that allows me to get that care.
I can't thank you enough for coming and sharing your story with us and with the American people. And just in a note of solidarity, I, like the gentlewoman from Georgia who spoke earlier, I'm a 2-time cancer survivor, but also Mary and I have 4 kids. The 2 oldest both have Crohn's disease and have for 14 years. And we would have gone bankrupt multiple times over just trying to pay for their medications if they weren't covered, and because of, caps, lifetime. We would have blown by lifetime caps already. So I really thank you for sharing your story. I yield back, Mr. Chairman.
Thank you. The gentleman from Kansas, Mr. Watkins.
Thank you, Mr. Chairman. My question is for Ms. Turner. Ma'am, I represent Kansas, and in Kansas, Kansans with pre-existing conditions face a number of challenges and hardships. And I'm glad that a lot of Democrats and Republicans agree that Americans with pre-existing conditions should, and have been for years, been protected, for decades actually. And so in that, of course, even before the Affordable Care Act. So unfortunately, since its passage, the ACA continues to be problematic. Premiums continue to rise. And the answer, I believe, is not to double down on ACA, but and seek a one-size-fits-all government-run healthcare regime. Therefore, Ms. Turner, since the passage of Obamacare, can you speak to the lack of actual affordability for the vast majority of Americans? Also, the rate of continued premium increases because of the law.
Premiums in the exchange markets have about doubled on average since the law since the exchanges took effect in 2014. That's much higher than in the regular market, and certainly before that. And the consequence of that is that it's driving more and more healthy people out of the market. The ACA, as you know, forces young people to pay a disproportionately high amount for their coverage because of the 3-to-1 age rating in the exchanges. And so we're losing, if young people are not eligible for their parents' coverage and trying to afford premiums on their own, they're paying a disproportionate amount for people who are older and sicker, and therefore they're dropping out as well. So I think it's crucial, if we really want to increase access to health coverage, that we figure out a way to get costs down and to attract the healthy people into the market. Senator Reeves' constituent in Virginia, he doesn't want to drop out of health insurance market, but he can't afford $4,000 a month for premiums and having no choices of coverage. So people need more choices. They need to be able to have more flexibility with benefits to protect their family, and they need some of these bridge plans like association health plans and short-term limited duration plans.
Thank you. I also want to touch on our increasingly strong economy propelled by comprehensive tax cuts and regulatory reform. In fact, CNBC recently noted that January job reports just last week, payroll surged by 304,000, smashing estimates. Thanks to recent pro-growth federal policy changes, more and more Americans are finally finding good-paying jobs. Many of these jobs offer generous employer-sponsored health care. Savvy employers simply know that they have to be competitive to attract good HR. So, Ms. Turner, can a strong jobs market spurred by pro-growth policies lead to increased coverage rates nationally for employers with pre-existing coverage? What are some policies that can continue fueling workforce participation?
You're absolutely right that employees highly value their workplace coverage, and the HR departments, especially for big companies, work tirelessly to try to negotiate the best benefits, the best drug formulary, and the access to the highest quality hospitals for their employees to attract them so that they won't go to a competitor. And there are how many? 2 million jobs, 2.5 million jobs that aren't filled now. Employers can't even find the workers to fill them. So being able to offer attractive, affordable health coverage with the flexibility to meet the needs of their workers, and having providers that are competing for that business to offer those lower cost, higher value plans, I think is really a crucial part of a thriving economy.
Thank you, Ms. Turner. I yield back, Mr. Chairman.
Thank you. Gentleman from Maryland, Mr. Trone.
Thank you, Mr. Chairman. Ms. Corlette, 30 years ago, I started my business with my wife and 2 little girls, and I know firsthand starting a business can be scary without the fear you're going to be able to afford health care for yourself and your family. You mentioned prior to the ACA, people are often tied to jobs they'd have otherwise left, but simply because they needed to maintain health care, access to affordable health insurance. Could you elaborate on what the ACA's protections for patients with pre-existing conditions has meant for entrepreneurship, startups, and small business creation?
Sure. So before the ACA, if you were leaving a job-based plan, you were required to maintain what was called COBRA coverage, which was continuation coverage, but you had to pay the full premium. And for most people, that was unaffordable. And so people often had a lapse in coverage. And then if you had a pre-existing condition, it was almost impossible to find an individual market plan to cover you and your family. With the ACA, you can now, if you have a business idea or want to go out on your own and start a consultancy or invent something, you can do so without having to worry that your pre-existing condition would cause you to be denied or have a pre-existing condition imposed on your exclusion imposed on your policy.
So, Dr. Gupta, the opioid epidemic, as you spoke about, you're from West Virginia. My district borders Western Maryland, so we're right there together in the heart of the opioid epidemic on I-81. I lost my nephew, age 24, to a fentanyl overdose a couple years ago, and so many folks in my district have been adversely affected by this tragedy. With the ACA, we closed a lot of gaps in coverage, especially in the area of behavioral health. And I think that's so important, and it's all part and parcel of this disaster, substance disorders. If the ACA was gone, what do you see as the human toll?
Thank you for that question. Certainly, we understand, states with border counties, populations don't treat those as states. They are one community within those areas. So it's very important for people to be able to move across and not have to worry about what's the state regulation in this state and the state regulation in that state. ACA allows that consistency to happen state to state. The mental health protections, as well as the ability to get the help that need in people who have so many other challenges ongoing at the same time. ACA really allows that to happen. And I think that's the most important piece as we are combating this opioid crisis, is to be able to not have any extra barriers in terms of coverage and accessibility to care. As the good treatments are existing and more come up, we've got to be able to have the access to provide tens of millions of people who are suffering and dying, actually, tens of thousands per year, to be able to save them and then get them back to work.
As we put together legislation on opioids to address that, what do you see as a couple key points that should be in that to address the mental health connectivity, which is so crucial and part and parcel of this at all times?
I think it's very important for us to go back to see what we did with HIV. We realized HIV was much more of a social determinant aspect of this in the 80s, and we put together, the Ryan White Care Act, for example, that not just took care of you as an individual, your medication, but you looked at your house and your access and all those things. So I think it's very important when we look at this crisis, we're looking at housing, we're looking at access, daycare, all of those tools that surround somebody who's suffering from addiction, to be able to be provided so that they can get into treatment and then they can have a successful, fair chance of recovery and back into employment. So it's a lot more than just pills or just counseling. That is a societal response that we must have to this crisis in order to address it, and I think that's the part that we can do more, not less.
Okay, thank you. I yield the balance of my time.
Thank you. The gentleman from Indiana, Mr. Fulcher.
Thank you, Mr. Chairman, and panelists.
Excuse me,
and,
Addo, excuse me.
yeah, it's a common mistake. Thank you. Panelists, take heart. I think the end is near. It's coming close here, okay? And please forgive the lack of attendance by some of us on the front end. I, for one, am still struggling with the multiple committees at the same time, and so please know that wasn't rudeness. My question, and I'll probably address this to Ms. Turner because I know some of this has been covered, and I'm going to shorten things up because Mr. Watkins hit part of that. But in our state of Idaho, 2012, I think it was, I believe we were the only state with Republican leadership in the House, the Senate, and the governor's office that embraced the state-based exchange. And I was in the Senate leadership role at that time, and in hindsight, it just hasn't worked out well for us. Our insurance premiums across the board have averaged somewhere between a 15 and a 27% per year increase. And so as we speak right now in our state, there's a lot of things on the table that are being discussed right now, alternatives to try to figure out a better path. And I would just like to get your counsel, your input on some of those things, and I'll just list a few, but the expansion of HSAs, medical memberships, Medi-Share, charity care, the expansion of insurance procurement across state lines, which in our state we can't do, high-risk pool reform, those types of things, which are, they're more market-based. And given our history and our struggle with the status quo that there is, your thoughts, your counsel on that type of an approach?
States do talk about the difficulty of figuring out how to address the needs of their state, but it's even more than the state. It's sometimes at a county level. You have rural counties who have very different problems than Cincinnati and Canton and Cleveland. So they really need to have the resources and the flexibility to meet the needs of those areas. And I want to really reinforce what Dr. Gupta was saying about the social determinants of health. We put so much money just into health care when people may actually need other kinds of supports to make their lives work better. And I believe that Ohio is one of the states that is implementing work requirements as well for Medicaid. And people who work with these communities say that's a valuable thing to make sure that people have some place to go once they get through rehabilitation treatment, to have a job, something to give stability to their life, help them with housing. If states had more flexibility, and I believe the Trump administration is working to do that, as we've said before, Congress has repeatedly voted for money to dedicate money to high-risk pools. Many states that were doing, the states that were doing high-risk pools in the past were doing it all with state money. With the ACA, there's new money to put on the table to make those risk pools work better so that you can provide dedicated resources for them and more comprehensive care for chronic conditions. So care management for those high-end patients, being able to have more flexibility to provide the kinds of benefit structures that people actually want to purchase to protect themselves and their families, I think are really crucial. And hopefully we can work with Ohio and other states in trying to think about what some of those waiver options might be to make it work better for your state.
Thank you, Mr. Chairman. Quick follow-up, and I'll thank you. Ms. Turner, in a few words, because I'm going to yield my time here in just a second, but that makes sense. But when it comes right down to it, should we be focusing on solutions that come out of this room and out of this building and of the building next door? Or should we be focusing on more enabling market-based solutions to try to improve our situation?
We see in Medicare Advantage, for example, that market-based solutions to provide more comprehensive care, and I believe it is really based upon a formula very close to what traditional Medicare pays for Medicare Advantage, can give incentives to begin to find the same kinds of cost efficiencies in the health sector that we see in other sectors of the economy. When you have so much of the time of healthcare providers and administrators focused on following Washington's rules rather than figuring out what's best for the patient and what's best for our state, then it really takes away time and energy from solving the problem.
Thank you, panelists. Ms. Turner, Ms. Chairman, I yield back.
Thank you. Gentlelady from Michigan, Ms. Stevens.
I'd like to take a minute to thank our panelists today. Ms. Corlette, your expertise and knowledge is so welcome. We thank you for taking the time. Mr. Reedy, thank you for your courage and your words of wisdom and sharing your personal story. It was a delight to be in this room with your family, who was looking at you with very proud eyes. You are one of the reasons why the ACA was so critical and critical to every American taxpayer and American worker, and I admire you from the bottom of my heart. And Ms. Turner, I want to thank you for your eloquence and answering a lot of questions today. And Dr. Gupta, thank you for being here. As we're here examining threats to workers with pre-existing conditions, this topic could not be more critical. As our ranking member, Fox, indicated, we have a healthy economy, and the health of our taxpayers and our workers is paramount. And Dr. Gupta, I'd like to take my questions to you and your expertise, which we're delighted to have in the room today. In your testimony, you discussed the issue of high-risk pregnancy and delivery and how women prior to the enactment of the ACA often found that, they reached their policy's cap. They would reach their policy's cap on the amount of care provided. They'd find themselves exposed, financially unsupported in the workplace, and generally pushed to a brink. And so I'd like to ask you, what's the cost of a high-risk pregnancy, and how likely are women to run up against these caps in the absence of the ACA protections?
Certainly, thank you for that question. March of Dimes certainly is doing a lot of work around this because we know that maternal mortality and morbidity amongst the 49 developed countries in the world, we're number 49. We're actually 3 times mortality of the next country in line, which is UK. So we're really in a bad shape right now. We have women dying every single day. The cost can be tremendous. And when we look at the cost, really, it's not just human lives lost, but we're talking about one complicated pregnancy can cause that woman to lose potentially her absolutely full annual lifetime limit. So she may not have coverage for the rest of the year and have to take care of not just the baby, but the rest of the family. Same way we go back to the severe prematurity. One simple birth with severe prematurity can land a child, an infant, for multiple months in a neonatal ICU. So when the baby returns home for the first time, when there should be a cause for celebration, it would then be a cause that the baby could meet his or her lifetime limits on care and not be insurable until Medicare. And that's just a terrible thing to think about. And those are the challenges we're dealing with, where we need to be making progress to work in those maternity care deserts. We have a third of the counties in this country, or 1,000 counties, 5 million women, 150,000 babies that are being born with no obstetric care. So that we're actually, talking about walking backwards.
Well, and not only is this a cost to the mother and the family, it is a cost to the employer as we, are talking about the workforce and our economy writ large. And Dr. Gupta, as you know, the Affordable Care Act requires insurers to cover preventative health services without cost sharing. And these obviously include family planning, well-women visits, screenings for domestic violence, and other crucial health services. And just to back this out a minute, I'd love for you to just reflect on how pregnant women and other new mothers, utilize these services, and what impact would overturning these provisions, maybe through the Texas litigation, have on these women.
So first of all, just the idea of preconception care, to be healthy in order to get pregnant, is very important. that would not happen. Then within prenatal care, the notion of having things like folic acid and vitamins, which we think is very basic, we recommend that all across the globe, yet we can have women that can deliver and cause real harm to the babies developing because of neural tube defects and other things that are not being provided. Throughout the prenatal care, we know the amount of visits that happen with the doctor's office in this following the standard of care leads to better delivery, better care of that's not the mother, but also the baby, and as a result, getting the family dyad back together, the mom and baby. None of that would be possible if we were to remove that. And obviously, one of the things that used to happen was only time you can get in Medicaid was if you got pregnant. And then it would be removed the coverage right after. Now we have 60 days, up to 60 days coverage postpartum. When we're dealing with challenges of postpartum depression, suicide, postpartum hemorrhage, hypertension, eclampsia, heart conditions, it's very critical for us to build on that coverage postpartum up to a year because of the increasing maternal mortality that is happening. This is still the most dangerous place for a woman to have birth in the developed world. And we need to be working, again, not at removing that, but actually developing more systems. But at this time, removal of ACA provisions will cost women and their children not just their jobs, but potentially their lives.
Well, Dr. Gupta, while you don't share my gender, I appreciate you sharing the stories of women and mothers and making that at the forefront of our minds today. Thank you.
Thank you. The gentlelady from Nevada, Ms. Lee.
Thank you. I wanted to first thank all of the panelists today for your testimony and answering the questions. And Mr. Reedy, I wanted to speak directly to you. First of all, CF has had a place in my family. My husband lost a cousin about 30 years ago before groundbreaking technologies and treatments were available. And more importantly, my sister, Mary Lester, is a respiratory therapist at Keck Medical Center at USC and dealing with adult cystic fibrosis. So through her through my ears, and I have experienced alongside her many of the struggles that patients like you go through. So thank you very much for being here in your testimony. I wanted to ask, in your testimony, you pointed out that you're fortunate to have comprehensive health coverage through your wife's employer. If your wife were to change jobs, choose to start a small business, or possibly take time off for education, you might end up in a situation where you'd have to change this coverage. And I wanted to know from you, how do the Affordable Care Act's protections for patients with pre-existing conditions provide a peace of mind that you'd never be without coverage?
Thank you for that question. Knowing that my wife or I could switch employers and still be adequately covered, it gives us a peace of mind that allows us to be flexible and explore new opportunities, potentially, that before the ACA may not have existed. Without the ACA, there's always that fear that leaving a job, if I went to another one, that I could still be denied insurance because of my pre-existing condition, or if my wife changed jobs, would they deny me coverage because of my pre-existing condition?
And thank you. And to follow up on that, what impact would an adverse decision in Texas case have on your wife's ability to change jobs?
Well, if the ACA was, if the ruling stands, my wife would have less of the opportunity to explore new opportunities. She's a teacher, so she's at a great place right now, but if she had to, she wanted to do something other than teach or switch employers, there's still that fear that we may be, or I may be, denied coverage or access to it. So it could lock her into where she is.
All right, thank you. One other question. According to the Department of Health and Human Services, the number of Americans with pre-existing conditions ranges from at least 23%, 61 million people, to as many as 133 million people. And prior to the Affordable Care Act, these Americans with pre-existing conditions could be denied coverage or charged an exorbitant premium to get coverage, something that my parents had experienced, both having high blood pressure at one point in their lives. Some families have even declared bankruptcy from high medical bills due to having a pre-existing condition. Today, however, insurance companies cannot discriminate against people based on their medical history. Mr. Reedy, without employer-sponsored health insurance or insurance through your family prior to the Affordable Care Act, do you believe you would have been able to attain affordable health insurance?
Before the ACA, I would have likely been denied coverage because of my pre-existing condition without the access to employer-sponsored health coverage. And the ACA provides me with the opportunity to be adequately covered on the individual market currently. And without them, I don't know if that would be possible.
Well, thank you so much for your testimony. I want to say I texted my sister to tell her I was going to be speaking with you today. And she sent me this message back that said, please make sure we help people with cystic fibrosis because these patients need to have their medical needs met, and it's extremely expensive illness. She said they didn't cause this disease, but they must fight it. And so thank you for your courage for being here. I appreciate it.
Thank you. The gentlelady from Massachusetts, Ms. Strahan.
Thank you. Thank you, Mr. Chairman, for having this hearing, and thank you, everyone, for hanging in for a long hearing. Part of the challenge of being later in the program and new here is so many of the thoughtful inquiries have already been made, but I do have a couple of questions. I'm a mother of 2 young girls, 8 and 4, as well as 3 grown stepsons who have benefited from the ACA and being able to stay on my health plan as they enter the workforce. Before the ACA, women were often charged more than men just because of their gender, and some couldn't even get coverage on the individual market. For women of childbearing age, the discrimination was particularly blatant, and the vast majority of plans excluded maternity coverage of any kind. And I appreciate my colleague from Michigan and her inquiry around maternal care. Dr. Gupta, I'm wondering if you could just explain to us what it was like for women to get health insurance coverage before ACA, and how many plans covered maternity coverage in the individual market, and what improvements have women and their families seen since ACA?
Certainly, thank you for that. We know that prior to the ACA, only 11 states mandated the coverage of maternity care. Only 13% of the individual health market actually covered maternity care. We know that at that time, obviously, the gender of being female was a pre-existing condition to effect. We also know that 47% of people who tried, adults who tried to get coverage with pre-existing condition, were either denied, charged more, or were precluded from at least one condition. That's from the Commonwealth Fund study. So we know that this was a big problem. Since then, Marcia Dimes did a study in 2015 and found that between 2013 and 2015, from the uninsured coverage for child-bearing age women went down from about 20 million to 13 million, 20% to 13%. That means that another 5.5 million of childbearing age gained coverage. Not only that, the unmet needs actually went down by 10% points of those women. So clearly that has been a big gain. I would say that when we talk about pre-existing conditions, health inequities are the first cause of pre-existing conditions. And when I talk about maternal mortality, a black woman in this country is more likely to die 3 to 4 times more than a white woman. So we still have, for healthcare institutions across and healthcare systems across the country today, race is a pre-existing condition. And we need to continue to work on that, and I think that's a critical piece that I must bring up as well.
Thank you. Thank you, Dr. Gupta. And Ms. Corlette, To borrow a phrase that's going around a lot, the dignity of work is something that means a lot to me. And I'm the daughter of a union iron worker. My mom worked multiple part-time jobs while raising my sisters and me. I'm constantly thinking about how are we going to support work and labor as it transitions to the future and what the future of work actually looks like. We talk a lot about our economy and adding more jobs, but those don't always translate into employer-sponsored plans. So a recent Department of Labor survey found that 10% of the workforce are categorized as either independent contractors or self-employed. This represents a growing segment of the workforce. In fact, more than half of all ACA marketplace enrollees are small business owners, self-employed individuals, or small business employees. I'm wondering if you've looked at any additional research on the impact of the Texas lawsuit, or even just the 70-plus ACA repeal attempts would have on the future of work. And also, if we have time, can you discuss the impact of removing pre-existing condition protections for gig economy workers, independent contractors specifically?
Sure, thank you. It's a great question. So for folks who do have job-based coverage, there are a couple of things to be concerned about if the Texas court decision stands. One, of course, is that people could lose, with chronic or high-cost health needs, could lose some of the protections that Mr. Reedy has spoken so eloquently about. The other issue, of course, is job lock. And this is a phenomenon that was well documented before the ACA, where folks sort of hung on to their jobs and their job-based coverage because of the uncertainty of the individual market. And they may have had a great business idea or been a terrific entrepreneur, but did not pursue that because of their need to maintain job-based coverage.
Great. Thank you. Thank you, Mr. Chairman. I yield back.
Thank you. The gentlelady from North Carolina, Dr. Adams.
Thank you, Mr. Chairman, and thank you all very much for your testimony and for sitting this out with us. We appreciate that very much. Mr. Reedy, thank you so much for sharing your story. Mr. Chairman, I'd like to enter into the record first from some organizations that have commented regarding the pre-existing conditions and the GOP plan. First, the American Cancer Society Action Network, who says that these protections are hollow if patients and survivors can't afford insurance. From the American Health Care Association, the plan would do just the opposite and not serve the health needs of all Americans. And then they also say that the greatest achievements of the ACA is protecting those with pre-existing conditions. The National Disabilities Rights Network says that that GOP plan permits discrimination against people with disabilities in the insurance market for pre-existing conditions. And I'd like to enter this to the record, Mr. Chairman. Thank you. Let me just say, as I've listened to you, all of you, I thought about Dr. Martin Luther King Jr., who talked about health care and inequities, and who said that of all the forms of inequality, injustice in health care is the most shocking and most inhumane, and indeed it is. I do want to just mention the impact that ACA has had on communities of color, in particular, the protections for those with pre-existing conditions. I am a diabetic, and that's an illness that was is considered a pre-existing condition. It's very prevalent in my family. I had a sister who suffered with sickle cell anemia, a pre-existing condition, who passed away before she was 27. African Americans are 80% more likely than whites to have been diagnosed with diabetes. About 365 African Americans suffer with sickle cell anemia. Latino Americans have the highest rates of cervical cancer, and Asian women are the highest risk of osteoporosis. Simply put, the Affordable Care Act has saved lives and has provided health care to millions who previously thought affordable treatment was just a dream. Folks like me families that grew up who didn't have health care at all, no health insurance, having to go to the emergency room to get our care. Dr. Gupta, just one or two questions. For those with pre-existing conditions or minority communities, how many more people with chronic illnesses have been covered? And have those who suffer from chronic ailments seen improvements in their conditions as a result?
I can tell you that there has been a great progress made in that, and I'll certainly get you the exact numbers, but the great progress made in that, in the ability to, again, people to be covered. And I say that because these conditions are a part and representative of your socioeconomic condition. They're representative oftentimes of the culture we come from, and lots of other things, what we call social determinants of health, education level. So being able to provide the basic health care that has happened as part of the Health ACA has allowed our communities of color actually to be have one less thing to worry about. So that's one of the things. The other piece I will go back to, as March of Dimes, we're focused on the health of moms and babies. And nowhere is it more evident, the disparities and health inequities, than we look at moms and babies. As I mentioned, 3 times to 4 times more likely to die if you're a black woman. Same way, prematurely, twice as likely to die if you're a premature child who's African American. So these are the type of things that we are fighting for, and I think it's very important to understand that this will take us many steps backwards, and we need to be moving forwards.
Great, thank you very much. Wanted to just, note that since the president assumed office, we've seen a constant attack against ACA, so much so that we're seeing a reversal in quite a bit of the progress that we've made. And just wanted you to just briefly comment on how this reversal in progress has impacted people of color specifically.
I think what would once again end up happening, we will have individuals who will be dependent again on emergency care and urgent care, as a result of which screenings will not happen, preventive visits will not happen, as a result of which we will not be able to catch those diseases early. It will be delayed, it will be more expensive, and it will cost more lives. As Ms. Corlette eloquently pointed out a couple of times, that we have clear data before ACA, that when people were uninsured, there were about over 20,000, 22,000 people that we know in this country were dying every year because of the lack of insurance, per se. We will go back to that.
Thank you very much. I yield back, Mr. Chairman.
Thank you. Gentlelady from Minnesota, Ms. Omar.
Thank you, Chair. Thank you all for being here. Thank you for having this really important, critical conversation, but sometimes frustrating conversation. I say frustrating because of 2 reasons. One, to see the disconnect between what some of my colleagues would say in committee about healthcare and what their votes say about where their priorities and their values are, seems very, very frustrating for me. And the second is for us to have conversations about policy that have real impact on humans, but to not really think about the humans that we're talking about in this discussion. So I'm one that sees healthcare as a human right, and I want to take some time for us to humanize this particular conversation, because there are people who will talk about the costs. They will talk about what struggles corporations will have, or companies will have, or small businesses, or all of these kind of things. But oftentimes we don't talk about the kind of stresses and the traumas that people like yourself, Mr. Reedy, have lived with, as you not only deal with getting the diagnoses and figuring out how you go on with life, with a condition that could be a hindrance to your day-to-day life, or could maybe end your life. So what I wanted to do was maybe have you walk us through what it must have been like to go through the process to receive those letters from insurance companies before the passage of the ACA?
Thank you for the question. This was back in 2007, and to know, have spent 7 days in the hospital, and to know that what the cost of that care is. And then after that, I also spent 14 days at home on IV antibiotics at home, which required a home health care nurse who came every couple of days to draw blood and just check on the dressing and the IV and everything. But to receive information that describes the cost of your care, is a shock to see how much it actually costs. But then to see how that is then compiled towards a limit of what an insurance company or someone is willing to pay is worrisome. It's scary because you know that without that care or access to that, without access to the coverage that will give you that care, it will be much harder for you to stand a chance. And not just for me, but for others with CF or with other pre-existing conditions that face those same struggles. It takes a toll not only on us as people, but also on our families and those that love us, because it's not just me that would sit and think about it, it's my wife, right? And my kids are, at the time, at 2007, they weren't alive yet. But now if that was to happen again, that puts an unnecessary burden on them as well. And having the knowledge that there are no caps and not having to receive those letters anymore allows us to focus on our family and to continue to seek the best coverage and care that allows, in medicines that are highly specialized, to target what the issues are with my disease and to help prolong my life so that, like I mentioned earlier, I can see my children grow up and go to college and not fear that I may have to make a decision one day so that they can continue to grow and me not have to have that coverage.
Thank you. I see an immorality in the way that we are creating policy without taking in the actual impact that it has on the people's lives. We take a constitutional oath to protect the safety and the well-being of the people that we serve. So thank you so much for sharing your story. And I will tell you that you have people here in Congress who will make sure to constantly center that. So thank you. I yield back.
Thank you, and I recognize myself now for questions, and the vote's been called, so these are going to be some quick questions. Appreciate some quick answers. Ms. Corlette, you mentioned the New York situation where they covered, they guaranteed issue notwithstanding a pre-existing condition, and when the Affordable Care Act came in, is it true that the cost for individual insurance dropped more than 50%?
Yes, it's true.
The effect of the Texas case, is it true that if the case is upheld, there will be no protection, national protection for pre-existing conditions?
The ACA protections will be struck down, yes.
We've heard that if it's unconstitutional, the court would provide some transition time. Is there any, you're a lawyer, is there any guarantee that there'd be a transition time if they call it unconstitutional?
There is no such guarantee.
Now, the repeal and replace, are you familiar with the American Health Care Act that passed the House?
I do remember it, yes.
Okay, is it true that if that had passed, 23 million fewer people would have insurance, costs would go up about 20% the first year, and there'd be fewer consumer protections?
I don't remember the exact numbers, but that sounds like what I remember, yes.
And we've heard a citation in the bill that protects people with pre-existing conditions, but what wasn't read was an ability for states to waive that protection. So if you are unlucky enough to be in the wrong state, that you could have no protection against pre-existing conditions. Is that right?
Right.
11 million people who have who got coverage through Medicaid expansion, would they lose their coverage?
Yes.
And the 10 essential benefits, including prescriptive drugs, mental health, maternal and newborn care, preventive care, would those evaporate if the ruling is upheld?
Yes.
And we've heard about essential benefits, and Dr. Gupta has been very articulate on that. If maternity care were optional, who would buy it?
Well, who would offer it is the first question. Insurance companies generally would not offer it. And if they did, it would typically be as what's called a rider, and the cost would be exorbitant.
Because the only people that would buy it would be those who expect to have a baby in the next year, and the cost would be not insurance, but essentially prepaid maternity care.
That's exactly right.
And that's why it would be unaffordable. Now, on the association plans, as I understand it, you can get a healthy group, young, healthy men, and who would pay less. Arithmetic, therefore, says everybody left behind would pay more. Is that right?
That's correct.
Now, the navigators, which you mentioned, are community-based organizations that help consumers sign up for coverage. Language recently published by the Centers of Medicare and Medicaid states that priority will be granted in funding organizations that promote, quote, coverage options in addition to marketplace plans such as association health plans, short-term limited duration insurance. Is that consistent with the original purpose of the navigators?
No, navigators are supposed to help people enroll in marketplace coverage.
Do you know what has happened to the rate of bankruptcy because of medical bills as a result of the Affordable Care Act?
I don't have that data at my fingertips, but it has gone down.
And can you say another word about job lock and why the Affordable Care Act gives people, particularly entrepreneurs, the opportunity to switch jobs?
Sure. So for people who have a pre-existing condition themselves or somebody in their family who has a health condition, economists documented this phenomenon called job lock, which prior to the ACA led a lot of people to stay with job-based coverage, even if that job was not optimally deploying their skills or talents. Since the ACA, if you are an entrepreneur or you want to start your own business, you can do so without worrying about coverage for your pre-existing condition. And if you're at least initially not earning much income, you can qualify for subsidies or even Medicaid.
Thank you. I'd like to thank our witnesses for their testimony. I recognize the distinguished ranking member for closing comments.
Thank you, Mr. Chairman, and I want to thank our witnesses also for being here. I particularly appreciate the opportunity that this hearing has given for Republicans to set the record straight on our position on pre-existing conditions. I believe most every member spoke to it, but we know that every member believes in coverage for pre-existing conditions, both those of us who are here to vote for the replace bill and the numerous replacement bills that we have offered. There's so much to say to correct the record here that there's not enough time. Perhaps I will submit some things for the record, but I want to point out that if the court rules the ACA illegal, it would not repeal ERISA. It would not repeal HIPAA. There are safeguards in both of those pieces of legislation for pre-existing conditions. Some of our witnesses have been extremely careful in how they have answered those questions, and I appreciate that because they've been very careful not to completely mislead people about that situation. Contrary to what has been said about the work of Republicans, we've made provisions in all our proposals and passed legislation that protects people with pre-existing conditions. and I think it's important we continue to say that. The Affordable Care Act was built on lies. If you like your insurance, you can keep your insurance. If you like your doctor, you can keep your doctor. All of those things were said, and costs will be lowered. Those were not true. The ACA ordered people into a one-size-fits-all plan, which increased costs dramatically, and we know that. What Republicans have done is to offer Americans freedom and choice. And what we should have been talking about today was what the ACA has done to raise the cost of health care and make it less affordable and less accessible. And with that, again, I thank the witnesses and I yield back.
Thank you. Again, I want to thank the witnesses and members for their participation. What we have heard, I think, is very valuable. The hearing has allowed us to take stock of where we are, to examine attacks on pre-existing conditions through unnecessary litigation, harmful rules that have a negative impact on those with pre-existing conditions. And I think we should try to improve and protect the health care that we have now and not jeopardize it. It's obvious that even the employer-based coverage with the protection for pre-existing condition, those with employer-based coverage, if we don't have the individuals covered, we'll have uncompensated cost shifting, so they will be paying more if all of these other protections are repealed. If there's no further business to come before the committee, the hearing is now adjourned.
Floor staff holding the vote for you.